Hello guys, welcome everyone to the Physics Wala NEET PG. Dr. Patil here, and in next 3 hours we will be quickly revising the important previous year questions from the NEET PG. I'll not take too much of your time. I'll directly start with the questions. So let me begin with the first question. This question is from neurology, mainly on the topic headache, and we all know that almost every NEET PG exam has one question from the topic of headache. So let's go through the question. In this question, a woman in her early 40s, so relatively young female, was taking analgesic regularly for headache for the past 6 months. She was taking analgesics for 6 months. The intensity of headache increased in severity for last 3 days and reduced when she stopped taking analgesics. What is the likely diagnosis? So is it cluster headache, tension type of headache, chronic migraine, or medication overuse headache? This type of questions are becoming recurrent questions these days, so we should be aware. Okay, so now when we talk about headache, we all know that headaches are classified as primary and secondary headaches. Primary headaches include tension type, migraine, and what we call as trigeminal autonomic cephalgia. Under this trigeminal autonomic cephalgia, I want you to remember cluster headache. Cluster headache is a type of trigeminal autonomic cephalgia. Then we also have what is called as paroxysmal hemicrania. Paroxysmal hemicrania, and a very peculiar form of headache called as short lasting unilateral neuralgiform cephalgia with conjunctival tearing, or short lasting unilateral neuralgiform headaches with autonomic symptoms, or SUNA. Okay, now how do I make a diagnosis of these primary headaches when I get a question? We come to the diagnosis of primary headaches after ruling out the secondary headaches. The secondary headaches generally have some red flag signs. Generally, they will have red flags present. Okay, so what are the major common causes for secondary headache? Secondary headaches can be because of infections. That includes CNS as well as extra CNS infections. Need not always be meningitis or meningoencephalitis. It includes both the infections, extra CNS infections, like you have dengue, viral fever, enteric fever, you still have headaches, right? Infections, then intracranial space occupying lesions, intracranial space occupying lesions, and when I say intracranial space occupying lesions, that includes tumor eats the brain in the space in the brain, tumor, bleed, as well as abscess. Tumor, bleed, as well as abscess. Okay, now in the recent years, examiners are particularly interested in this secondary form of headache called as medication overuse headache. Medication overuse headache. Now the case may be a primary headache. Like let us say I am dealing with a female with a tension type of headache, and to relieve her I might prescribe some NSAID, maybe paracetamol or some other NSAID. But if she overuses it, that dependency on the medication itself triggers the headache, and the best way to confirm that it is medication overuse headache is stop the medicines. If headache improves after stopping the medication, it is medication overuse headache. If headache does not improve after stopping the medications, it is not medication overuse headache. Then again you have to think of uncontrolled primary headache. Okay, now what are the diagnostic clues in a case of primary headache disorders? Okay, tension type of headache is generally bilateral, migraine is unilateral, and all these trigeminal autonomic cephalgias are also unilateral. Okay, tension type of headache usually described by a patient as band-like sensation, which is a very, very important clue in any question. Band-like sensation or voice-like grip. If the question is about migraine, generally examiners mention that patient had photophobia, phonophobia, nausea or vomiting, and may have aura, right? As we all know, may have aura. Aura need not always be present, aura plus or minus. So these features are clue towards migraine. All these TACs, trigeminal autonomic cephalgias, cluster headache, paroxysmal hemicrania, and Santorsuna, they are associated with autonomic symptoms. What are those autonomic symptoms? They can have redness of the face. Redness of face. You can also call it as flushing of face. Then second thing they can have is they can have lacrimation. While headache, unilateral headache is going on, the same side, which side the headache is affecting, they will also have tearing or lacrimation. They can also have nasal stuffiness or nose blocks. Nasal stuffiness or nose blocks. So if any question is talking about unilateral headache with these features, it is talking about one of these. Any question which is talking about unilateral headache with photophobia, phonophobia, nausea, vomiting, and some kind of aura is talking about migraine. Any question where you see headache and band-like sensation or voice-like grip is talking about tension type of headache. And any question which says headache resolved after stopping the analgesics is talking about medication overuse headache. Improves upon stopping NSAIDs, then it is talking about medication overuse headache. So now going back to this story, we cannot diagnose it as cluster, tension type or chronic migraine from the story because sufficient information is not there. The question is not talking about unilateral, bilateral. The question is not talking about whether additional features were there, whether aura was there, whether patient was describing it as band-like sensation. No clue. Of course, I cannot commit to any of these diagnoses, but improvement in the headache when she stopped taking the analgesic points towards medication overuse headache. So option D, as most of you had pointed, will be our answer. Okay. Now let's go to the next question. In this question, we have a known case of mitral stenosis. We're talking about a known case of mitral stenosis who presented with breathlessness, which is one of the very common symptoms, and chest pain. So we're talking about dyspnea and angina in her early 20s. The patient is in her early 20s. On examination, the pulse was irregular, and on echocardiography, no thrombus was found. Best agent to prevent future thrombotic events is. Now from the question, what's your diagnosis? We are dealing with a case of mitral stenosis. What is the most common cause for mitral stenosis? Please remember, the most common cause for mitral stenosis is rheumatic heart disease, as we all know, is RHD. Okay, and mitral stenosis can lead to various complications, and one of such complications is atrial fibrillation. Complications of mitral stenosis include increased risk of atrial fibrillation. Now please remember, in mitral stenosis, what is the problem? In a mitral stenosis, the mitral valve opening is narrow. Because of that, let us say that this is the left atrium that I am talking about, and this is the left ventricle, and this is my aorta. Here I have aortic valve, and this is where we have the mitral valve, and this is left atrium, this is left ventricle. So if this mitral valve opening is narrow, when I want to transfer the blood from atria to ventricle, it poses challenge, restricts the flow of blood, and that results in pressure buildup in the left atrium. And to compensate for that pressure buildup, the left atrium dilates. So if there is mitral stenosis, then there will be left atrial hypertrophy. And whenever we distort the architecture of the left atrium, it increases the risk of developing atrial fibrillation. One more complication that this left atrial enlargement can lead to is this enlarged left atrium can now go and compress the left recurrent laryngeal nerve, and compression of the left recurrent laryngeal nerve results in hoarseness of the voice, and we call this condition as Ortner's syndrome. What is the mechanism behind this? The mechanism is compression of left recurrent laryngeal nerve compression of left recurrent laryngeal nerve by enlarged left atrium or by left atrial hypertrophy. Now if I have atrial fibrillation, that means the atria is not contracting, merely shaking, and that results in one of the component of Virchow's triad called stasis, and stasis, as we know, increase the risk of developing a left atrial thrombus, right? It increases the risk of left atrial thrombus. And if there is a formation of a left atrial thrombus, from the left atrium it can come down to left ventricle, from left ventricle to aorta straight away to the middle cerebral artery through internal carotid artery, and it can lead to stroke. So mitral stenosis is associated with increased risk of embolic stroke, increased risk of embolic stroke. Now all of us know how to make a diagnosis of atrial fibrillation on the ECG. It's a narrow complex tachyarrhythmia with absent P waves and varying RR interval. It's a very simple diagnosis. But in the absence of ECG, how we could make the diagnosis of atrial fibrillation? Because in this question, the moment you tell me that this is a case of mitral stenosis, I should keep in mind the possibility of these complications. Atrial fibrillation is also a possibility. The clue here is irregular pulse. So this irregular pulse in the context of mitral stenosis is suggestive of AFib. What other clue the examiner can give in the question? What other clue we can expect in the question? Clues for AFib. So the first clue, as we just discussed, is irregular pulse. Irregular pulse. And the second clue for atrial fibrillation is pulse deficit more than 10 per minute. Now can anybody tell me what do I mean by pulse deficit? Pulse deficit. So please remember, pulse deficit refers to, pulse deficit is difference between simultaneously measured heart rate and pulse rate. Simultaneously measured heart rate and pulse rate. So if the difference is less than 10, it could be some ventricular ectopics or normal physiology. But if it is more than 10, it is suggestive of atrial fibrillation. Higher the number, the chances of patient having atrial fibrillation is much higher. So this question is not talking about pulse deficit, but it has mentioned that there is irregular pulse. So now my diagnosis in this case, what is going to be my diagnosis? The diagnosis is I am dealing with rheumatic heart disease, most likely resulting in mitral stenosis with atrial fibrillation. And as we all know, once there is atrial fibrillation, there is increased risk of stroke. So we need to think of stroke prevention strategies. In the normal context, when it's not about mitral stenosis, let us say just we have a patient with atrial fibrillation and I have to prevent stroke. Should I give anticoagulants or manage with aspirin alone? That decision will be based on a parameter called as CHA2DS2 WASC score. So we use this to decide about anticoagulation in patients with AFib. Why I have to give anticoagulation? Because as I just told you, atrial fibrillation increases the risk of developing a left atrial clot, and this clot has a tendency to embolize, right? So choices are, I can think of aspirin alone or aspirin plus anticoagulants. That decision will be based on CHA2DS2 WASC score. It's not very difficult, easy to remember because it itself is a mnemonic, where C stands for congestive heart failure, H for hypertension, A for age more than 75 years, D for diabetes mellitus, S for stroke or TIA history, V for vascular diseases like the peripheral vascular disease or the ischemic heart disease. ischemic heart disease. Then another A here stands for age 65 to 74. So there are two A's here, age more than 75 and 65 to 74. And SC stands for sex category, that is female gender. Now here we are calling it a CHA2 and DS2. That means for every letter we are going to give 1 point, but for the first A we are giving 2 points and first S we are giving 2 points. That means congestive heart failure is there, patient will get 1 point. Hypertension is there, patient will get 1 point. But age more than 75 years he will get 2 points. If he is diabetic he will get 1 point. If patient had stroke in the past or history of TIA, he will get 2 points. That is S2. Stroke or TIA history, 2 points. Vascular disease, 1 point. Age not more than 75 but 65 plus, then again 1 point. And if it is a female gender, we give 1 point. This is how we calculate the CHA2 DS2 VASC score. Once it is calculated, we have to see how much is it. If it is more than or equal to 2 for males, or if it is more than or equal to 3 for females, it needs anticoagulation in addition to aspirin. But for the scores lower than this, means less than 3 for female, less than 2 for males, in such cases aspirin alone is enough. Aspirin alone is enough. Okay. Now in this question, they have not mentioned any of this information, right? Whether the patient is hypertensive, whether she had a past history of TIA or stroke, then how will I calculate? No, examiner is not asking you to calculate the CHA2 DS2 VASC score. There are 3 conditions where you will start anticoagulation without looking at the CHA2 DS2 VASC score. What are those 3 conditions? So please remember, there are 3 conditions where anticoagulation is started without looking at anticoagulation initiated without CHA2 DS2 VASC score. So what are those conditions? The first one is atrial fibrillation in patients with rheumatic heart disease or valvular heart disease of other etiology. So if you have a rheumatic heart disease or if you have valvular heart disease and then you have developed atrial fibrillation, we do not have to calculate CHA2 DS2 VASC score, directly start anticoagulation. Second condition is if previous stroke. Don't calculate. Even if you want to calculate, it's not a big deal because it will come more than or equal to 2. Why? Because for previous stroke we are giving 2 points, and if I find 2 points for males, I start anticoagulation, and if I get 2 points from the stroke, anyway 1 point I'll get from the sex category for female, so it will become 3. I will start anticoagulation, right? The third one, which many of you may not be aware of, it is in patients with hypertrophic cardiomyopathy also. Hypertrophic cardiomyopathy. So these are the 3 conditions where you don't have to calculate the CHA2 DS2 VASC score, just start anticoagulation. So for this question, I have to start anticoagulation. The question is which one? So even if I take different turns, ultimately I come to the conclusion that it needs anticoagulation because this patient has rheumatic heart disease, he has valvular heart disease, it calls for anticoagulation. Which one? So please remember, for valvular heart diseases, though conventionally speaking, these newer oral anticoagulants like dabigatran are superior, but there are no sufficient studies in rheumatic heart disease and many other valvular heart diseases. That's why whenever we have rheumatic heart disease, right, in such cases we prefer warfarin. In the future, as more and more studies come, we may ditch that and switch to the newer oral anticoagulants, but as of now, for rheumatic heart disease, we have to stick to warfarin. So now please remember, the anticoagulant of choice. Anticoagulant of choice. Okay, so if it is AFib in RHD, AFib in patients with valve replacement, and for all other patients. So if it is AFib in RHD patients and I need to start anticoagulation, it has to be warfarin. Warfarin. If this patient with a valvular heart disease has been subjected to valve replacement, then in the valve replacement we have two types of prosthetic valves. One is bioprosthetic valve. If I am using bioprosthetic valve, then I can use newer oral anticoagulants like dabigatran, apixaban, zimmelgatran. But if I am using metallic prosthetic valves, again, I don't have sufficient studies to say that newer oral anticoagulants are as good as warfarin here, so I have to go ahead with warfarin again. So now tell me, what all conditions we are using warfarin as an anticoagulant? We are using it for all RHD patients, and those who have undergone valve replacement with metallic valves, we are using the warfarin. For every other patient, preferred agents will be newer oral anticoagulants or direct acting oral anticoagulants. So there is a potential that they may ask these parameters in the upcoming MCQ, so please remember this. So now what should be our answer for this question? Dabigatran is a newer oral anticoagulant. It's a Novak. But because we are dealing with it, it can't be the answer. Aspirin alone, no. As I've already told you, if it is rheumatic heart disease or valvular heart disease, we have to start anticoagulation directly, not applying the CHA2 DS2 VAS score. Aspirin plus clopidogrel is all antiplatelets, not adequate. So answer will be option C, oral warfarin. That will be our answer for this question. Right, so please remember the CHA2 DS2 VAS score, high potential for asking an MCQ. These are also potential points for asking an MCQ, and these are also potential points for asking an MCQ. Okay, now let's move to the next question. Patient presenting with mid-diastolic murmur and JVP showing prominent A waves. What is the most likely diagnosis? Anybody trying to give an answer? The patient presented with mid-diastolic murmur and JVP shows prominent A waves. Okay, well, prominent A waves on the JVP indicates what? First of all, only when right atrial pressure gets altered, we will have a prominent A wave. Right atrial pressure has to rise. So most likely, if I have to choose, I would probably choose right heart pathologies over left. We all understand that left heart pathology eventually leads to right heart dysfunction and I can have raised JVP. But if I have to pick directly, I have to primarily pick the right heart pathology, right? That's one. Second, what all valvular heart disease present with mid-diastolic murmur? I think all of you got it right. Very good, right? So what we will do is, we will first put a small table of all the valvular heart diseases, murmurs and area of auscultation. So please remember, when I have aortic stenosis, in aortic stenosis, the aortic valve opening is narrow. So when I try to eject the blood from left ventricle to aorta, it provides resistance, there is turbulence created and I will have a murmur. So when do I eject the blood from left ventricle to aorta? During the systole. So in aortic stenosis, the murmur that I am going to hear will be systolic and we will call it as ejection systolic. Ejection systolic. And because it has a diamond shape, we will call it as ejection systolic crescendo decrescendo murmur. Crescendo decrescendo murmur. And please remember, the pulmonic valve is the right-sided counterpart of the aortic valve. Same time when the aortic valve opens, same time the pulmonic valve also opens. So the murmur of pulmonic stenosis will be exactly same as aortic stenosis. Same, ejection systolic crescendo decrescendo murmur. So in the question, how will I get to know whether this is talking about AS or PS? Simple, the area of auscultation. So if the murmur is heard in the aortic area, which is the right second intercostal space, it is suggestive of aortic stenosis. Same murmur, ejection systolic, crescendo, decrescendo murmur, but heard prominently in the left second intercostal space, which is pulmonary area, then it is pulmonic stenosis murmur, right? Then mitral stenosis and tricuspid stenosis will have the same murmur. So when I try to transfer the blood from right atrium to right ventricle or left atrium to left ventricle, the narrow openings of these valves will create the turbulence and I will hear it as murmur. So I transfer the blood from atria to ventricle during ventricular diastole. So I am going to get the murmur, which is going to be diastolic. So in mitral stenosis, I will have the mid diastolic murmur with pre-systolic accentuation. So we will have a mid diastolic murmur with pre-systolic accentuation. What do I mean by pre-systolic accentuation? The murmur intensity increases towards the end of the diastole. Pre-systolic accentuation. And in tricuspid stenosis, I am going to get the exact same murmur. Then what is the difference? The mitral stenosis murmur will be heard loudest in the mitral area, which is at the apex. And in case of tricuspid stenosis, the murmur will be heard loudest in the tricuspid area, which is left lower sternal border. Left lower sternal border. Okay. Now the murmur of AR and PR are going to be same. The murmur of aortic regurgitation is early diastolic murmur, early diastolic decrescendo murmur, decrescendo murmur. That will be same for the PR as well. The area of course differs. So the murmur of AR is better heard in the left third intercostal space, which is called as Erb's area. Erb's area. But the murmur of PR is better heard in the pulmonic area, which is left second intercostal space. Okay. Now the murmur of MR. The acute MR may have an early systolic murmur, but chronic MR is more common. So classically chronic MR will have a pansystolic murmur. So same is the case for TR as well. Again, the areas where it will be heard differs. So the murmur of MR will be loudest at the apex, and the murmur of the tricuspid regurgitation, that is tricuspid area, which is left lower sternal border. Left lower sternal border. So now once we know this table, we will be able to deal with most of the valvular heart disease related questions. All you need to know is there are only 4 murmurs, 8 conditions, 2 conditions will have 1 murmur, and each valve has a dedicated area for its auscultation. Now going back to it, what are we getting in this question? We were dealing with a mid diastolic murmur. So what are the mid diastolic murmurs? MS and TS. These are the only 2 possibilities, MS and TS. Mitral regurgitation is ruled out because mitral regurgitation will have pansystolic, and tricuspid regurgitation is also ruled out because this will also have pansystolic. Now tricuspid stenosis and mitral stenosis both will have the mid diastolic murmurs. Both of them have mid diastolic murmur. But between the two, tricuspid stenosis is more likely to have the rise in the JVP and prominent A wave over mitral stenosis, because tricuspid stenosis, as soon as it develops, it will have raised right atrial pressure. Mitral stenosis will have raised right atrial pressure only when the increase in the left atrial pressure results in increase in the pulmonary vein pressure, and that results in increase in the pulmonary capillary pressure. Eventually there is increase in the pulmonary artery pressure. Then there will be development of right ventricular hypertrophy, and then right atrial pressure will increase, and then I can have raised JVP. So there is a long journey. But if I have tricuspid stenosis, as soon as I develop tricuspid stenosis, the opening is narrow, Right atrium struggles to push the blood into the right ventricle. Pressure in the right atrium starts rising. It reflects on the GVP, right? So that's why we are going ahead with option A as the answer over option B. If it is multiple right answer question, then you can choose both A as well as B, because mitral stenosis can eventually lead to pulmonary hypertension and thus eventually will have a prominent A waves as well. Okay, so that's about this question. Now let's move to the next question. Okay, so here we are dealing with a chronic alcoholic patient. In all our NEET PG exams, the moment they mention alcoholic, usually it is not a random mention. Examiner wants you to think about something, like either the question may be talking about, let us say, thiamine deficiency, right? Or the question may be talking about some cerebellar dysfunction or maybe some liver disease. So chronic alcoholic patient presented with abdominal distension, swelling of legs and reduced urine output. His creatinine was 1.6 milligrams per deciliter. What is the next line of management in this patient? So what do you think is the diagnosis here? Chronic alcoholic. He has abdominal distension, swelling of the legs and reduced urine output. Any question which talks about alcoholic, abdominal distension and swelling of the legs, what's your diagnosis? So of course we are thinking of cirrhosis of liver or chronic liver disease, right? So our diagnosis, we are thinking of cirrhosis of liver. The ascites can be explained, abdominal distension can be explained by the presence of ascites, and ascites can be explained by development of portal hypertension. Portal hypertension. Okay. Now, extra pointer here. This is my initial diagnosis when the question says there's a chronic alcoholic with abdominal distension and swelling of the legs. But now the urine output is reduced. So what complications I should think of with creatinine also increased? So this cirrhosis of liver has resulted in a complication. What is the complication I'm thinking of here? We are thinking of what is called as hepatorenal syndrome. We are thinking about hepatorenal syndrome or HRS. Can anybody tell me what is the mechanism for developing hepatorenal syndrome? What is the mechanism for developing hepatorenal syndrome? Okay, Akhil, good. Naman, good. What is the mechanism? So one, ascites increases the intra-abdominal pressure, right? So inside the peritoneal cavity, there is pressure build-up because of the ascites. Okay. Second, the portal hypertension is associated with splanchnic vasodilatation. So there is pooling of blood in the splanchnic circulation. So please remember, portal hypertension can result in pooling of blood in splanchnic circulation. What does that mean? Means the blood is pooled more in the splenic vessels and other components of the splanchnic circulation. Means circulating blood volume which is supposed to go to other organ is compromised. More blood is pooled in the splanchnic circulation itself. So there is reduced renal perfusion. So in that case, hepatorenal syndrome should be considered as pre-renal AKI or renal AKI or post-renal AKI. Mishra, Arpit, very good. So hepatorenal syndrome is technically a pre-renal AKI. It's a pre-renal AKI. So two things are happening here. One, increase in the intra-abdominal pressure, that is compressing and compromising on the blood flow to the kidneys. Second, more blood is pooled into these splanchnic blood vessels and less blood is available to go to the kidney. Right, so it is basically decreased perfusion of the kidney, so it's a pre-renal AKI. Now if I have to treat it, what should I do? What should I do? I have to increase the blood flow to kidney, right? How do I increase the blood flow to kidney? Well, if I'm giving diuretics and all which is making kidneys lose fluids, I have to of course stop them. But most importantly, I have to constrict the splanchnic blood vessels, so that the blood which was now pooled into the splanchnic circulation comes back to the main circulation and goes to kidney. Kidneys are perfused and they recover their functions. So which of these drugs can do that job? Which of these drugs can do this job? Methylprednisolone? No, nothing to do with our hepatorenal syndrome, right? Where do we use, if I am talking about a liver disease, where do I use methylprednisolone? Where methylprednisolone is used? For liver disease. Good. So methylprednisolone for liver disease is used for, is considered as a drug of choice for alcoholic hepatitis, right? Alcoholic hepatitis. It is a drug of choice for alcoholic hepatitis, but not useful for hepatorenal syndrome. So that's not going to be my answer, right? Heparin, of course, not required, especially in a patient with cirrhosis of liver who is already having coagulopathy because of the vitamin K dependent factor deficiency. Giving heparin can lead to catastrophes, right? Torsemide, a diuretic in case of hepatorenal syndrome. In fact, I should withdraw if the patient is on, right? We need to give them a holiday from diuretics. Withdraw diuretics, because I want to increase the circulating blood volume if it is a case of hepatorenal syndrome. So that cannot be my answer. So what's going to be my answer? Octreotide plus albumin. How albumin is going to help? Albumin helps, again, albumin is an oncotically active substance, so it helps you to retain more blood, more fluid in the circulating blood. So in liver disease, we have lost albumin, that is resulting in fluid exiting the circulation and going into the third spaces, so that can come back to circulation. Plus octreotide. Octreotide is known to cause vasoconstriction of the splanchnic blood vessels. So that will be our correct answer. But if you also had a choice called terlipressin, which one would you choose? Terlipressin plus albumin or octreotide plus albumin? So terlipressin is more effective in causing splanchnic vasoconstriction than octreotide. So preferred agent will be terlipressin. So in place of octreotide, if they also mention like there is another option, then please remember terlipressin will be preferred. Terlipressin is preferred over octreotide. Preferred over octreotide. Okay, clear? So that's about this question of hepatorenal syndrome. I think I have already written it down here. Terlipressin is preferred over octreotide for hepatorenal syndrome. Okay, now let's go to the next question. Here we have an elderly man, 72-year-old, brought in with complaints of cough with yellowish sputum. On examination, his respiratory rate is 20 per minute. BP is 110/70. He is not confused and is hemodynamically stable. Lab report showed urea level of 44 milligrams per deciliter. What is the next best step in the management of this patient? Give antibiotics and send the patient home. Consider admission in a non-ICU setting. Admit to ICU with invasive mechanical ventilation or admit to ICU without mechanical ventilation. Okay. Ignoring all this, what is the first option that you can rule out? What is the first option that you can rule out here? See, the decision to put someone on ventilator is based on various factors. One of the reasons to put someone on ventilator is respiratory distress. This question is not talking about respiratory distress. Second is severe hypoxia, not responding to non-invasive modes. This question does not talk about it, right? Third is if the patient is having a GCS less than 8. This question does not talk about it. So one thing that I can comfortably rule out in this question is with admit to ICU with invasive mechanical ventilation. The decision is not based on the parameters given here, right? So now I have to choose whether I should just treat it as an outpatient or admit, and if I am admitting, whether he goes to a non-ICU like regular inpatient or he becomes an ICU patient, right? So on what basis we decide where the patient goes? If it is presenting with these symptoms. What is the diagnosis here? The diagnosis here, we are dealing with an elderly man presenting with cough and yellowish sputum. So which is suggestive of respiratory infection. Let me call it as community acquired pneumonia. Community acquired pneumonia. So if I am dealing with community acquired pneumonia, whether to treat him as an outpatient or inpatient will be based on 𝐒𝐝 65, right? So decision to hospitalize will be based on 𝐒𝐝 65. In fact, there are two parameters that can be used, or two tools. One of them is 𝐒𝐝 65 and the second one is pneumonia severity index, or PSI. Okay, PSI, you will never get a question on it, means asking you to calculate, because it is complex and cumbersome. But one MCQ point I want you to remember, PSI is superior to 𝐒𝐝 65 in predicting mortality, superior to 𝐒𝐝 65 in predicting mortality. That's why it's the best tool to decide whether the patient should go as an outpatient or inpatient. But because it is cumbersome, you don't get MCQs on it. If they're asking, they will only ask which one is a better choice. If they're asking which one is the better choice between the two, it is pneumonia severity index, or PSI. But 𝐒𝐝 65 is a simple tool, it can be applied. So we will see like what are the components of the 𝐒𝐝 65. 𝐒𝐝 65 itself is a mnemonic where C stands for confusion, U stands for the urea or the bun more than 19 milligrams per deciliter. Okay. Then R stands for respiratory rate more than or equal to 30 breaths per minute, and S stands for systolic BP less than 90 millimeters of mercury, or diastolic less than 60, or in other words less than 90/60, and A stands for age more than or equal to 65 years. So now tell me, what all pointers meet here? Is the patient confused? No. So he is not getting that C point, right? What about the urea? Urea levels are high, right? So bun levels will be high. So he should be getting 1 point for this urea levels. He will get 1 point for this urea level. Okay. Then respiratory rate is not high. It is just 20. He is not going to get any point for it, right? Okay. Then age wise, he will get 1 point. So I already got 2 points. So what do you think? Should this patient be hospitalized or treated as an outpatient? 0 to 1 outpatient, more than or equal to 2 inpatient, more than or equal to 3 ICU, right? So how much we got here? BP is fair, BP is fair, we are not giving any points, so we got 2 points. So when we get 2 points, so for the patient points are 2. So according to 𝐒𝐝 65, where the patient should go? Inpatient, right? He should go inpatient, not as an outpatient. So what should be our answer? We should admit him to the inpatient, but of course in a non-ICU setting. If the score was 3, like let us say he was hypotensive, right? BP is not recordable, or 80/40, then he would go into ICU, right? So this will be the correct answer. He will be admitted in a non-ICU setting. Yes, augmentin with macrolide or a respiratory quinolone in the injectable form will be considered as the antibiotic of choice. Okay, so option B will be our answer. I want you to by heart or remember the 𝐒𝐝 65 parameters. Once in the past they have asked what was the mortality when the score is more than or equal to 3. It was 22%. Again, not very important point, but at least you should know to calculate and apply it on the question. Okay, now let's go to the next question. A 29-year-old man complained of excessive fatigue by the end of the day that improved with rest. A very classical story. Fatigue by the end of the day that improved with rest. Whenever you read this statement, you already know the diagnosis plus history of ptosis, difficulty in speech, and swallowing was also mentioned. What is the most likely diagnosis? Whenever a question talks about fatigable weakness, you already know the answer, right? It's a pretty simple, straightforward question. We are dealing with myasthenia gravis. Duchenne muscular dystrophy or the systemic lupus erythematosus, of course, they may have some degree of fatigue or weakness, but it is not going to have a diurnal variation. Lambert-Eaton can have the diurnal variation because this is also a neuromuscular junction disorder, but the weakness is maximum in the beginning of the day, not by the end of the day, right? So whenever a question talks about diurnal variation of weakness, diurnal variation of weakness, the question is talking about neuromuscular junction disorder, right? This is equal to neuromuscular junction disorder. And within that, we already know that we have myasthenia gravis and Lambert-Eaton. In myasthenia gravis, weakness is maxing at or maxes by the end of the day, and in case of Lambert-Eaton syndrome, weakness maxes at the beginning of the day. Weakness maxes at the beginning of the day. Duchenne muscular dystrophy, they will have persistent weakness, so that's not the answer. Systemic lupus erythematosus, they may have persistent fatigue, that's not the answer. Lambert-Eaton is not the answer because the weakness is worsening by the end of the day, so we will stick to the diagnosis of myasthenia gravis. Okay, good. Next one. A patient developed carpopedal spasm, what you call as Trousseau sign, in a woman suffering with hysteria when she was hyperventilating. What could be the likely cause? So what do you think? Okay, so, Nasa, we have one more question on the myasthenia gravis, so we will discuss about the single fiber electromyography as well. And okay, so what should be the answer for this question? Carpopedal spasm, right? Trousseau sign, what is it suggestive of? Hypocalcemia, right? Suggestive of hypocalcemia in a woman suffering from hysteria and hyperventilation. Now in psychiatry, I don't know if they use this term hysterical hyperventilation, but in medicine we continue to use. So when someone becomes anxious and hyperventilate, what are they doing? They are increasing their respiratory rate. And there is one important point you have to remember, that the carbon dioxide clearance in the body, carbon dioxide clearance is directly proportionate to respiratory rate. The more the respiratory rate, more is the carbon dioxide wash out from the body. Indirectly, you can also interpret it as the partial pressure of carbon dioxide in the blood is inversely proportionate to respiratory rate. More is the respiratory rate, less is going to be the partial pressure of carbon dioxide, or less is the respiratory rate, more will be the partial pressure of carbon dioxide. So from this you understand that if someone hyperventilates, there will be washout of carbon dioxide. Now in the body, we know that we maintain the pH in the perfectly normal range of 7.35 to 7.45 by balancing the acids and bases. Our major base in the body is bicarb, as we know, and major acid in the body is carbon dioxide, because carbon dioxide dissolved in water becomes carbonic acid, right? So if I wash out carbon dioxide, if I wash out, what I am literally washing out? I am literally washing out acid. So I am losing acid. So what will happen then? I am developing alkalosis. Now, is this happening because of the metabolic abnormality or kidney dysfunction? No, this is happening because of respiratory overactivity. So what should I call it as? I will call it as respiratory alkalosis. Respiratory alkalosis. So hyperventilation results in carbon dioxide washout. Hyperventilation results in CO2 washout, and CO2 washout results in respiratory alkalosis and hypocalcemia. That's why when someone with hyperventilation comes with hypocalcemic signs, we don't give them calcium injections, rather we give them a polythene bag and ask them to breathe in the polythene bag, so that whatever carbon dioxide they are washing out, they rebreathe it, right? Okay, so answer here will be respiratory alkalosis, nothing to do with metabolic, and of course not acidosis. Okay. Next, okay, so someone was asking me why we are going to get respiratory alkalosis. It is primarily because of the shift of calcium from extracellular to intracellular compartment. This is again happening to maintain the electroneutrality. So when I lose the carbon dioxide, I am creating the imbalance between the positive and negative ions. In fact, I am losing negative ions. So to compensate, I have to reduce the positive ions from the circulation. So calcium gets into the cell. So we end up with hypocalcemia. Okay, so here's the next question. A woman is admitted due to persistent vomiting and is known case of diabetes. History of consuming outside food was given. On evaluation, blood pressure is 90/60. Diabetic, persistent vomiting. Her arterial blood gas report is shown below. What is the cause for her ABG findings? Because we're talking about diabetes, patient is having persistent vomiting and she is in hypotension as well. So there are three things: diabetes, vomiting, hypotension. Can diabetes directly without vomiting, hypotension lead to some ABG abnormality? Yes. Why it will lead to some ABG abnormality? Because diabetic ketoacidosis can happen, right? Good. Then second, can vomiting lead to some ABG abnormality? Yes, when we vomit, right, we are throwing out the gastric content. And what is the major substance in the gastric content? Hydrochloric acid. So I am losing acid from my body. So when I lose acid, there is a balance between acid and base. I lose acid, base in relation is more. So now I develop alkalosis, right? So alkalosis can happen because of vomiting. Then hypotension, BP is low, so blood supply to tissues comes down. So tissues are not getting sufficient blood, so they are not also getting sufficient oxygen. So they switch from aerobic metabolism to anaerobic metabolism. So, and when we switch from aerobic to anaerobic, we will end up with generation of more and more lactic acid. So that can lead to lactic acidosis. So three components mentioned here can lead to different ABG manifestations. So first let us see what abnormality we are getting and then we will answer the question. So persistent vomiting can lead to metabolic alkalosis. We will call it as metabolic because I am losing acid, hydrochloric acid, yes, the chlorine as well as the acid. So I am developing alkalosis, not related to respiratory abnormality, so we will call it as metabolic. I am getting metabolic alkalosis. So hypotension can lead to decreased tissue perfusion, and decreased tissue perfusion can lead to anaerobic metabolism. Anaerobic metabolism can lead to lactic acidosis. This can lead to lactic acidosis. Lactic acidosis is nothing but a high anion gap metabolic acidosis itself. Metabolic acidosis itself. Okay. Then third, diabetes. Diabetes itself is known to cause DKA, which is also a high anion gap metabolic acidosis. So if the ABG shows metabolic acidosis, then either diabetes or this hypotension can be a reason. But if ABG shows metabolic alkalosis, then it is most likely related to vomiting. So now let us look at the ABG. What is the pH? pH is 7.52. So we all know that when pH is more than 7.45, we will count it as alkalosis. So this is already suggestive of alkalosis. Once the acidosis versus alkalosis debate is sorted, we have to decide whether it is respiratory or metabolic. And for that, all of you know, you follow Rome or Rom's criteria. Respiratory, opposite, metabolic, same side, right? So what does that mean? We are applying this Rome or Rom's criteria to the pH and the PCO2, right? These are the two parameters we should see. We should see what is happening to pH. pH is increased above the normal value of 7.35 to 4.5. And what is happening to PaCO2? Normal PaCO2 is 35 to 45 millimeters of mercury. This is here decreased. So they are in the opposite direction. That means we are dealing with respiratory. Respiratory parameters pH and PaCO2 go in opposite direction. If it is a metabolic abnormality, pH and PaCO2 go in the same direction. Sapnasha, respiratory acidosis. Okay, I'll come to that. Respiratory acidosis generally does not lead to hyperventilation. Respiratory acidosis happens because of hypoventilation. So we just learned this formula, right? Carbon dioxide clearance is proportionate to respiratory rate, or carbon dioxide level in the blood is inversely proportionate to respiratory rate. So when you say respiratory acidosis, the ability of the lungs to exhale carbon dioxide is reduced, either because of decreased respiratory rate or because of lung pathologies. So that's why we start retaining more and more carbon dioxide and the blood carbon dioxide level starts rising. A very classical example is when you give narcotics or opioids, the respiratory rate decreases, and opioids are known to cause carbon dioxide retention or type 2 respiratory failure, because once you give opioids, the respiratory rate starts decreasing, carbon dioxide clearance starts decreasing, blood carbon dioxide level starts increasing. But yes, metabolic acidosis can result in increase in the respiratory rate, because the respiratory system wants to wash out carbon dioxide when you have metabolic acidosis. Because see, when we have metabolic acidosis, body is producing some extra acid, like let us say 𝐷𝐄𝐄, ketones and acids are being formed. To get the pH normal, the other acids I have to shuffle out. So I start exhaling more and more carbon dioxide. So that is a compensatory respiratory alkalosis for the metabolic acidosis that we have. Okay, so here the approach is simple. Alkalosis decided based on pH, and then looking at the direction of pH and PaCO2, we have concluded that we are dealing with respiratory here. So looking at it, it is suggestive of respiratory. So diagnosis here is, this patient is having respiratory alkalosis. Respiratory alkalosis. So what can be the reason for this patient? The reason for this patient's abnormalities. It can't be diabetic ketoacidosis, right? It can't be septic shock. Diabetic ketoacidosis, what do we get? We get metabolic acidosis. Metabolic acidosis. Septic shock leads to tissue hypoperfusion, lactic acidosis. Then it has to be again metabolic acidosis. Lactic acidosis is metabolic acidosis. Okay, now here why it is persistent vomiting? Because we got the metabolic alkalosis. Okay, so here we have got the respiratory alkalosis, not the metabolic alkalosis, because the carbon dioxide is decreased. If I had got the metabolic alkalosis, the carbon dioxide should have been in this following the same direction as the pH. Because both of them are in the opposite direction, it can't be metabolic alkalosis. So this is not a perfect answer here. And in renal tubular acidosis, please remember, renal tubular acidosis is also a form of metabolic acidosis. So ideal answer here should have been, if vomiting is the reason, it should have caused metabolic alkalosis. While framing the question, the values mentioned are slightly distorted. So if I have to choose one answer here, I would still go with persistent vomiting, because vomiting is known to cause loss of hydrochloric acid that results in the acid loss and thus metabolic alkalosis, and that should have been our answer, right? But at least respecting the pH values, we will stick to the persistent vomiting as the cause. So that's what we are making the diagnosis here as the respiratory alkalosis. pH is high, carbon dioxide level is less. So the ABG wise, the diagnosis is respiratory alkalosis. It's not metabolic alkalosis. I would expect, if vomiting is the direct cause, I would expect metabolic alkalosis on the ABG. Here it is respiratory alkalosis, but then what parameters? Okay, we can think it this way. I would rather take the diabetic ketoacidosis as the answer here based on one important point. What is that? Okay, again, we cannot choose diabetic ketoacidosis either. We have to stick to, while framing the ABG parameter, we have leaned towards respiratory alkalosis. Even if I want to fix it to the diabetic ketoacidosis, then I need primary ABG abnormality as the acidosis and then the compensatory respiratory alkalosis. Here it is purely respiratory alkalosis. Respecting the alkalosis as a parameter, we can go ahead with persistent vomiting as the answer. Okay, now let's go to the next question. A patient with chronic renal failure, CKD, who was on dialysis, brought to casualty when he collapsed suddenly. On examination, labored breathing was noticed and ECG showed tall tented T waves. What is the most likely acid-base imbalance that can be seen? So even if they do not mention, no, see, a mixed disorder. Okay, see, now here the pH is clearly on the alkalosis side. Of course, there can be a compensatory metabolic acidosis in compensation to the respiratory alkalosis, but the primary disorder is respiratory alkalosis here. No, what is Naman? We will see the ROMS criteria or Rome criteria that we talk about. We apply it for the pH and carbon dioxide, not for the bicarbonate. So the decrease in the bicarbonate is a compensatory response. Okay. So now we are dealing with chronic renal failure or CKD. So what are the complications we can expect in CKD? One complication we are already seeing, that is tall tented T waves, which is nothing but suggestive of hyperkalemia. What other complications we can get in CKD? The complications of CKD include, the first one, fluid overload. So patient can have edema and pulmonary edema, shortness of breath. Second, hyperkalemia is one of the life-threatening complications of CKD. Third, kidneys are important organs regulating the acid-base balance. So renal dysfunction can result in metabolic acidosis. Fourth, CKD related mineral bone disease. It causes hyperparathyroidism. Okay. Can CKD cause neuropathy? Yes, CKD is known to cause neuropathy. Then can CKD cause anemia? Yes. What is the main mechanism for CKD related anemia? It is due to erythropoietin deficiency. So these are all possible complications. The list goes on and on. There are plenty of complications. Okay, and they may ask you what is the most common cause for death in CKD. Can anybody answer what is the most common cause for death in CKD? It is not hyperkalemia. What's the most common cause for death in CKD? Kavyasri, good. The most common cause for death in CKD is none of these. They don't die because of these. Majority of them die because of MI or ischemic heart disease. Because CKD itself increases the rate of developing atherosclerosis, and majority of them, they die because of ischemic heart disease. Good, good. So here we are expecting to see metabolic acidosis. So which of these ABG fits into metabolic acidosis? First one, pH is fairly appearing in the normal range. Bicarbonate is also in the normal range. PCO2 is also in the normal range. This is normal, bicarb is almost normal, PaCO2 normal. So this ABG is normal ABG, right? There is no disorder. Here the pH is 7.14. Here also it is 1.4. It is 7.54, option C, right? So this is alkalosis. So that also kind of rules out the answer. It can't be. Now which kind of alkalosis it is? What do we do? ROMS, right? So let us apply that ROMS. pH is increased. What is happening to the PCO2? PCO2 is in the slightly decreased, right? 35 to 45 is normal. So if I take that as value, it is decreased. So they are in the opposite direction, right? They are in the opposite direction. So that means this ABG is showing respiratory alkalosis. Okay, the next one. These two are acidosis, right? Here we are dealing with acidosis. pH is less than 7.35. Now which one is metabolic and which one is respiratory? We have to look at the direction of the pH is decreased. PCO2 also here it is decreased. Okay, here the pH is decreased, PCO2 is decreased. So both of them are suggestive of metabolic acidosis. Okay, but here bicarb appears to be increased, so there may be a mixed disorder. But here bicarb is clearly decreased. So this is highly suggestive of a classical pure metabolic acidosis with compensatory decrease in the carbon dioxide. So I'm going to choose option D here as the answer over option C. Option D will be the answer. This is typical metabolic acidosis that we are getting. Here it appears acidosis is there, but bicarb is not significantly decreased. PCO2 is decreased. So this is potentially a mixed disorder. Here it is clearly a primary metabolic acidosis with compensatory decrease in the carbon dioxide. So we will stick to option D as our answer. So in the CKD, we were able to answer this question because we know in CKD, we are expected to see metabolic acidosis and this ABG fits into it. Okay. So now let's go to the next question. NASA, it's good. A woman presented with, again, so until and unless you need to calculate the appropriateness of the compensation, you don't have to waste time in the exam. As long as if you are able to get the answer logically right, just move on, because all these mathematical formulas, until and unless you clearly need to apply it, no need to waste our time. So here it's quite clear. Looking at the bicarb, it's a mixed disorder. Here we are fairly dealing with the metabolic acidosis. We can go ahead with it. Okay, good. And those who want a more detailed discussion on the ABG, on the Telegram, we have already done it. You can just search on the NEET PG Sankalp group and you can go through the whole discussion on the ABG. Okay, next. A woman presented with feeling of tightness on her face and numbness of her fingertips. Now, by the time you hear this, what disease comes to your mind? Right. We are thinking about the possibility of Raynaud's symptom, right? Raynaud's symptom. The numbness of our fingers is pointing towards Raynaud's phenomenon. Okay. Now the tightness on her face, what it could be? Unlikely that they are pointing towards a photosensitive rash. The malar rash is not usually described as the tightness. This is mostly suggestive of microstomia and fibrosis of the skin of the face, what we call as Moscow facies. Moscow facies. Where do we get Moscow facies? We get that in scleroderma. Okay. Now, can ANA be positive in patient with scleroderma? Should I think of only SLE whenever there is ANA positivity? No. No. Why no? Because ANA in the titer of 1:40 can be positive in 5% of the population. Me, you, or one of us may be having ANA positivity. Only when we take 1:80 titer, okay, lesser number of population will turn out to be positive, right? So ANA is not very specific. It's a very sensitive investigation for various rheumatological disorder, but it's not very specific either. But the pattern, the immunofluorescence pattern may hold some clue. So from the clinical story of this tightness on the face and a Raynaud's phenomenon put together, we are thinking of the possibility of scleroderma already. But there is a vague possibility of SLE as well. So that is where the ANA pattern will come into picture. So I have summarized a small table of ANA pattern and associated rheumatic diseases, and I have highlighted few. Okay. So if you are dealing with nucleolar pattern, in case of the SLE, you can either get homogeneous pattern or you can get speckled pattern in SLA. But if you are getting nucleolar pattern, you should think of, there are two types of scleroderma. You can think of diffuse cutaneous systemic sclerosis. And if you are getting this centromere pattern, in fact, you remember, right? One of the antibody that you get in scleroderma is the limited cutaneous scleroderma is anti-centromere antibodies. So if you are getting this centromere pattern, you should think of limited cutaneous systemic sclerosis. SLE can manifest in various patterns: homogeneous, speckled, peripheral rim pattern. But if you are getting nucleolar or centromere, think of scleroderma. If it is nucleolar, diffuse cutaneous, and if it is centromere, think of systemic sclerosis, limited cutaneous. So here, what is the point that they have mentioned? It is showing the nucleolar pattern. So that means I am not thinking of SLE here, right? So in SLE, I can get homogeneous or speckled pattern. Systemic sclerosis is what I am thinking of. More precisely, what I am thinking of, diffuse cutaneous variant. We are thinking of diffuse cutaneous variant. So our answer is going to be option D, systemic sclerosis, where we get this nucleolar pattern. Now, can anybody tell me what all diseases, what all complications this patient is at increased risk of? Diffuse cutaneous variant. Diffuse cutaneous variant, right? So please remember, diffuse cutaneous variant patients are at increased risk of, developing, number 1, interstitial lung disease, number 2, interstitial lung disease, and the second one, increased risk of developing what we call as scleroderma renal crisis. Scleroderma renal crisis. And these limited cutaneous patients, they are at increased risk of number 1, fingertip ulcers. Number 2, they are at increased risk of developing pulmonary arterial hypertension. They are also at increased risk of developing esophageal dysmotility, and then calcinosis of the soft tissues, including skin, which you often remember it as calcinosis cutis. Now, this diffuse cutaneous variant patients are classically positive for anti-SCL70, which is also called as anti-DNA topoisomerase. Topoisomerase antibody, and also anti-RNA polymerase 3 antibody. And these patients of limited cutaneous are usually positive for anti-centromere antibodies. So in the exam, they may ask you to identify whether it is diffuse cutaneous or limited cutaneous based on the antibody or the ANA pattern. So if it is nucleolar pattern, it is diffuse cutaneous. If it is centromere pattern, it is limited cutaneous. If it is anti-centromere antibody, it is limited cutaneous. If it is anti-SCL70 or anti-DNA topoisomerase, then it is diffuse cutaneous. Having diffuse cutaneous puts you at risk of developing ILD and scleroderma renal crisis. Having limited cutaneous puts you at risk of developing the pulmonary arterial hypertension. That is something that I want you to remember. In the last NEET PG, they had also asked one more question. What is the most common cause for death in systemic sclerosis or scleroderma, right? So if they ask that question, overall the most common cause for death is pulmonary arterial hypertension. And if they ask you what is the second most common cause of death, the second most common cause of death in the systemic sclerosis patients is going to be interstitial lung disease. Okay, again, one more easy way to remember which one is for the limited cutaneous and which antibody is for the diffuse cutaneous. Simple, remember, think about a cell. Okay, cell has a nucleus. Now, if I have to find centromere, where will I find the centromere? Centromeres are in the chromosome, and where do I get that? Inside the nucleus, right? But if I have to find the DNA, where all I find? DNA is present inside the nucleus. Can it be present outside the nucleus? Yes. Where else it will be present? In the mitochondria, you have this circular DNA, right? There's also free DNA in the cytoplasm. So DNA is diffusely present in the cell, and centromere has limited presence. It is only present inside the nucleus, and that too, chromosome is not always visible, right? So only during the replication, at some stage, the chromosomes align and centromere will be visible. So can I say that centromere has limited presence? So you can say that anti-centromere antibodies for limited cutaneous. And DNA has diffuse presence inside the mitochondria, inside the nucleus, inside the cytoplasm. So thus this anti-DNA topoisomerase is for diffuse cutaneous, right? So that's how you can remember. Centromere, limited presence. DNA, diffuse presence. So we are sticking to the diagnosis of the systemic sclerosis here because of the ANA pattern as well as the other features which are more aligning with the scleroderma. Okay. Is there any effective drug to treat the scleroderma? Bhargavi Pulicherla, good, very good. Unfortunately, we don't have effective drugs for treatment of scleroderma. We only treat the complications. Patient develops pulmonary arterial hypertension, we treat it. If they develop esophageal dysmotility, we give prokinetics. So we can only treat the complications. But for SLE, rheumatoid arthritis, of course, we have specific newer drugs available. Okay, let's go to the next question now. A woman in her mid-40s. So they are telling the age is in her 40s. It's a known case of hypertension. Was brought to the emergency room with loss of consciousness, chest pain and diaphoresis, sweating. Bilateral pulses were unequal and she was grossly unstable. ECG showed non-specific STT changes. What is the next best investigation? So from the story, what's the diagnosis you're thinking of? See, when someone complains of chest pain, what are the differential diagnoses we have? That is acute onset, right? Brought to the emergency room. It's not like chest pain going on for months or years together. So DD for acute onset chest pain. Acute chest pain. What are the differential diagnoses for acute chest pain? Of course, our priority diagnosis, top differential diagnosis will always be the acute coronary syndromes, including stable angina, including unstable angina, NSTEMI and STEMI. These are going to be my primary first important differential diagnosis, right? Second, it can also be acute pericarditis. Third, it can also be esophageal injury, that can be either Mallory-Weiss tear or Boerhaave syndrome, through and through tear or mucosal tear. Okay. Fourth, the acute onset chest pain can also be because of pleuritis. And fifth, it can also be because of pericarditis. And one more equally important is aortic dissection of aorta, and rarely even rupture of aorta. Dissection of aorta as well as rupture of aorta. These are two different entities. Okay, so these are the possible differential diagnosis. Now, what investigations I can do to rule out acute coronary syndrome? Of course, ECG and cardiac troponins, right? So here they are not mentioned anything about troponins, but if it is positive, they would have. So I will presume that it is negative. ECG, they have mentioned non-specific STT changes. Okay, so already it's not leaning in favor of acute coronary syndrome. Second thing, the bilateral pulses are unequal. So added this information, chest pain not showing the STEMI changes and bilateral unequal pulses. What does it point towards among the lists I have mentioned? Can I have unequal pulses in acute pericarditis? No, right? Can I have unequal pulses, one side more, one side less, in case of esophageal injury? No. If I have, let us say that I have Boerhaave syndrome, my esophagus is completely ruptured, I am bleeding, I may get into hypotension. So my pulse may become feeble, but I will not have bilaterally unequal pulse. Pleuritis? No. Pericarditis? No. So what are we leaning towards? We are leaning towards aortic dissection. So when there is dissection of aorta, I can have bilateral unequal pulse. So for all your NEET PG questions, whenever they mention, and I'm talking about acute condition, not chronic, right? So if there is acute chest pain plus bilaterally unequal pulses, plus bilaterally unequal pulses, think of it as dissection of aorta. Dissection of aorta. Now the question is, what is the investigation of choice for the dissection of aorta? What is the investigation of choice for the patient with dissection of aorta? Mr. Arpit, good. So either you can go with the CT angio or transesophageal echocardiography, right? Now cardiac enzymes are not going to help me diagnose the dissection of aorta. If I am strongly suspecting an acute coronary syndrome, they can help me. X-ray is not useful, MRI is not useful. So either I have to go for transesophageal echocardiography or CT angio. Among the given options, I am going ahead with the transesophageal echocardiography. Right. So CT angio, of course, as Naman mentioned, it's a good investigation, but then we need to ship the patient to the radiology, get the CT angio executed and get him back. Not always convenient. Transesophageal echocardiography can be done in the ICU itself, right, without shifting the patient, without taking that risk of moving out an unstable patient. Okay. But if they're asking what is the investigation of choice, if given a choice, if condition permits, I will always go ahead with CT angio, right? The amount of details I can get from the CT angio, I will not get from the transesophageal echocardiography. So this is an alternative to CT angio. Stability of the patient becomes an important factor. Okay. Next, a patient presents with seizure. On evaluation, urine osmolality is 1000 milliosmoles per kg and serum osmolality is 270 milliosmoles per kg. What is the expected electrolyte abnormality? Sangeeta Reddy, yes, in coarctation of aorta also you can have unequal pulses. and in fact your upper limb pulses will be more prominent than the lower limb pulses, but it's not an acute condition. That's why I said if the question is talking about acute onset, then only think of dissection of aorta. Okay, a patient presents with seizure. On evaluation, urine osmolality is 1000, serum osmolality is 270. What is the expected electrolyte abnormality? Okay, how many of you think it is hyponatremia and how many of you think it is hypernatremia? So comfortably, two options can be ruled out, that is option C and D, because potassium levels have nothing much to do with the serum osmolality. Their contribution to osmolality of the blood or the plasma is negligible. Sodium is the main contributor to the serum osmolality. In fact, you might remember this formula for serum osmolality. Formula is 2 into sodium plus glucose divided by 18 plus Bun divided by 2.8. Means what are the three major osmotically active substances in our plasma? Sodium, glucose and Bun. And what is the normal serum osmolality range? 280 to 294 milliosmoles per liter. Now to maintain this, of course, antidiuretic hormone is working constantly. But out of this 280 to 294, how much of this is coming from the sodium? How much of it is coming from the sodium? What is the normal sodium value? Normal sodium value is 135 to 145 millimoles per liter. Millimoles per liter. That's a normal sodium value, right? So let me take a median value of it. Median of it, let us say 140. Average value 140. So if I have to calculate the serum osmolality, how am I calculating? 2 into sodium, right? 2 into 140. How much is that? That is 280. So in the normal range of 280 to 294, 280 is already coming from sodium, right? So the amount of osmolality contributed by glucose and urea in physiological state is negligible. Sodium is the single most important determinant of serum osmolality. So if sodium value decreases, what should happen to serum osmolality? Should decrease. And if sodium value increases, serum osmolality should also increase. If you have low sodium with normal serum osmolality, what do you suspect? So in this case, what is happening to the serum osmolality? Serum osmolality is decreased. So as we just understood, decreased serum osmolality should point towards decreased sodium. So we will go ahead with hyponatremia as our answer. Hypernatremia will be associated with increased serum osmolality. Increased serum osmolality. So this patient is probably having the SIADH. So that's why he is losing large amount of sodium in urine. So that's why his urine osmolality is high and he is having hyponatremia, 270 milliosmoles. So that will be our answer. Now if you have hyponatremia or low sodium with decreased serum sodium with normal or increased serum osmolality, then it is not true hyponatremia. Then we will call it as pseudo hyponatremia, because whenever sodium goes down, whenever sodium truly goes down, you should have decrease in the serum osmolality. So one of the requirement for the diagnosis of SIADH is also that you should have low serum osmolality. Serum osmolality should be less than 280 to diagnose it as SIADH, because true hyponatremia is required. But if I have, let us say, sodium value of 120 but serum osmolality is 290, then it is not true hyponatremia, it is pseudo hyponatremia. No, in the sodium has very minimal influence on the ECG changes. So that's why whenever we think of sodium, think of brain. When you think of potassium, think of heart. Potassium has a significant influence on the cardiac conducting system. So you will have mostly cardiovascular complications. Hyperkalemia leads to all the ECG changes. Hypokalemia leads to ECG changes. Hyperkalemia can even lead to cardiac arrest, sine wave and arrest. When you think of sodium, think of brain. There's a reason also. See, when sodium decreases, what happens to the serum osmolality? Serum osmolality decreases, right? So let us think about this brain and the blood vessel. Okay. Now when sodium decreases, what happened to the osmolality of the blood? Serum osmolality decreased, right? Osmolality of the serum decreased. And the chemistry and physics, we have learned that fluid moves from hypoosmolar to hyperosmolar. Here the osmolality of the cells in the brain is normal, but serum is decreased because serum sodium is reduced. So now water should move from blood to brain or from brain to blood? Water should move from blood to brain. What is the rule of osmosis? Fluid moves from hypoosmolar to hyperosmolar fluid. Hypo to hyperosmolar. So here the brain cells are hyper in comparison to the blood, right? So relatively they are hyperosmolar. So water from the blood moves into the brain cells, neurons. And when water moves into the brain cells, what do we call it as? We call it as cerebral edema. So hyponatremia leads to cerebral edema. And the cerebral edema leads to raise in intracranial tension and all the complications. Hyponatremia can even lead to death. And reverse can also happen in hypernatremia. In hypernatremia, the osmolality of the plasma is higher than the brain cells. So water from the brain cells will drain into the blood, causing the dehydration of neurons, again neuronal damage. So sodium has more impact on the brain, potassium on the conducting system of the heart. So that's why when you see symptoms of hyponatremia, they are all related to brain, right? Okay. So let's go to the next question now. The clinical presentation with feeble femoral pulses associated with upper limb blood pressure of 186 by 90 millimeters of mercury and chest x-ray showing enlarged intercostal arteries. What is the likely diagnosis? Ideally, the question should not be framed like this. Rather, chest x-ray may be showing rib notching. Rib notching. What is the diagnosis? I think someone was asking me a point related to this, right? Feeble femoral pulses and upper limb blood pressure is 186 by 90 millimeters of mercury. So indirectly I can say that, see, please remember, how strong we feel the pulse depends on the systolic BP, right? The peak of the pulse is proportionate to systolic BP. So when you say feeble femoral pulse, that means femoral artery systolic BP is low, and when you see the upper limb systolic BP, it's high. So when you have upper limb BP higher than, greater than lower limb BP, what does it suggest? Physiologically, which limb is supposed to have higher blood pressure? Physiologically, our lower limb is supposed to have higher blood pressure, up to 20 millimeters of mercury higher systolic BP than the upper limb. So like normal patients, if you check their upper and lower limb BP, right, let us say 120 is the systolic BP in the upper limb, lower limb is going to be higher. It can be up to 140. Up to 140. So 20 millimeters of mercury difference can be there between upper and lower. That is perfectly physiological. Why that happens? Because when heart distributes the blood between the upper and lower limb blood vessels, because of gravity, it gives more blood to the lower limbs. So that's why lower limb BP will be slightly higher, up to 20 millimeters of mercury. This gap can increase, means lower limb BP will further go up, more than 20 millimeters difference may come, like it may become, let us say 160. In that case, it is 40 millimeters difference, right? That happens in conditions like aortic regurgitation. In conditions like aortic regurgitation, where you call it as Hill's sign. It's called as Hill's sign. Lower limb BP higher than upper limb by more than 20 millimeters of mercury seen in aortic regurgitation. But what we are seeing here, upper limb is higher than lower limb. So what does that mean? Normally heart gives more blood to lower limb than upper limb, but something is stopping it from giving more blood to the lower limb. That's why lower limb BP is going down. When does that happen? It can happen in dissection of aorta. It can happen in coarctation of aorta. If I'm thinking of acute, maybe I can think of dissection of aorta. But when I'm thinking of chronic, I should think of coarctation of aorta. Now in this question, there is an additional pointer. So when there is coarctation of aorta, the blood flow through the intercostal vessels increases, they become hyperplastic, and those increased or enlarged intercostal arteries can cause the notching of the ribs. So this rib notching plus these two differences is suggestive of coarctation of aorta. Coarctation of aorta. So we are going ahead with the diagnosis of coarctation of aorta. Now bicuspid aortic valve, how does this present? Patient with bicuspid aortic valve, how do they present? Sindhu, yeah, we can have the radiofemoral delay even in patients with Takayasu arthritis. Bicuspid aortic valve, initially it will be asymptomatic. Eventually these patients present with either aortic stenosis in 80% patients, and 20% of them may develop aortic regurgitation. Aortic regurgitation, right? So none of them, neither AS nor AR explains the finding we are getting. If it was AR, I would expect to have much higher lower limb BP than upper limb. That is what we call as Hill sign, not seen here. In case of AS, if BP reduces, it will be reduced uniformly in upper and lower limb, right? Atrial septal defect, it is mostly going to be asymptomatic until and unless there is a reversal of the shunt. Once there is reversal of the shunt, patient will have cyanosis, right? So the only story that fits into the picture here is the coarctation of aorta. Okay, so this is a X-ray of a patient with the coarctation of aorta, where you can see the notching of the ribs, and also the figure 3 sign in case of coarctation of aorta, right? This anyway Rishabh will cover in the radiology as well in sufficient detail. Okay, so let me now take you to the next question. A patient has undergone circumflex artery bypass and is a known case of course, atherosclerosis. Stent placement was successful. He was already taking lisinopril, verapamil and metoprolol. Okay, so there is something wrong in framing this question. I wouldn't say bypass, rather circumflex artery angioplasty, because I have mentioned that there was a stent placement. He was already taking lisinopril, verapamil and metoprolol. Now which drug should be added? Patient presented with some symptoms. He has undergone circumflex artery angioplasty was done. Why will we do angioplasty? Probably he would have developed an acute coronary syndrome, right? So when someone develops acute coronary syndrome, we generally go for angioplasty. Now tell me, which valve he would be having MI? Which valve you expect him to have MI? Artery is already mentioned, right? Which blood vessel, which valve the circumflex artery is supplying? The circumflex artery is primarily supplying the lateral valve, right? It has a little bit of contribution to the inferior valve. So majority of the blood supply to the lateral valve is coming from the left circumflex artery. So mostly this patient would have the lateral valve MI, has undergone an angioplasty and stent is placed. This patient probably was already a known case of IHD or stable angina, and for that he was on lisinopril, verapamil and metoprolol. Now which drug should be added? So whenever we have a patient with acute coronary syndrome, right? Whether it is STEMI, NSTEMI or unstable angina, we do consider antiplatelets. So for first 1 year, we give dual antiplatelet therapy, and then after 1 year, we give single antiplatelet therapy lifelong till a complication or a contraindication emerge. If no contraindication, we keep giving one antiplatelet agent lifelong. But first 1 year, for an acute coronary syndrome patient, we give dual antiplatelets. If it is a stroke, we give dual antiplatelets for only 21 days. Remember, this is also an MCQ point. For stroke, of course, ischemic stroke, DAPT is for 21 days or 3 weeks, not for 1 year. But for acute coronary syndromes, it is for 1 year. So now we are dealing with an acute coronary syndrome. I need to give 2 antiplatelet agents for 1 year. Is there any role of phosphodiesterase inhibitor, 3 inhibitor or direct acting oral anticoagulants? Of course no. So we can comfortably rule these options out. So what should be my answer? Like P2Y12 receptor blocker. We will be giving along with aspirin, right? That is how we get dual antiplatelet agents. Okay. Now, with respect to cardiovascular system, where do you use phosphodiesterase 5 inhibitors? CVS, I'm not asking about other system. CVS. Now, anticoagulants in metabolic valves, we give lifelong. Phosphodiesterase 5 inhibitors like sildenafil, tadalafil, which cardiovascular disorder we use? For pulmonary arterial hypertension. So for treatment of pulmonary arterial hypertension, we do use, yes, good. Okay, so let's go to the next question now. All of the following statements are true regarding pheochromocytoma. I think all of you should be able to answer this. This is a repeatedly asked question. Except, true except. Regarding what? Pheochromocytoma. Okay, so can anybody tell me what is a pheochromocytoma? Pheochromocytomas are the catecholamine producing tumors. These are catecholamine producing tumors. What are the catecholamines? Adrenaline, noradrenaline, dopamine. So tumors that produce catecholamines, mainly originating from the adrenal medulla or the sympathetic ganglions, will be called as pheochromocytoma. Okay. Now when they produce catecholamines, those catecholamines will be released in circulation, not continuously but periodically, intermittently. So every time a surge of catecholamines, adrenaline, noradrenaline or dopamine comes into blood, they are all potent vasoconstrictors. They can cause vasoconstriction, hypertension. They can also trigger palpitations because they also have chronotropic action. So they can cause increase in the heart rate and increase in the BP, right? Both episodic hypertension, episodic palpitation. Many a times these patients are often misdiagnosed as panic attacks, right? Only later or on evaluation we get to know that they don't have panic attack, but rather they have pheochromocytoma. Okay. Now what is the screening test of choice if I am suspecting pheochromocytoma? What is the initial investigation or the screening test? Can I check adrenaline, noradrenaline or dopamine levels? Can I check adrenaline, noradrenaline, dopamine levels? If they are high, like it's pheochromocytoma? No. Why I can't check? Because these tumors release adrenaline, noradrenaline, dopamine intermittently, not continuously. So if I check between the two events where it is released, in between, when it is not getting released, it will come normal, right? So we cannot rely on the adrenaline, noradrenaline, because once it is released, they act for a very short period, increase the heart rate, increase the BP, and then once they are degraded, they are no longer detectable in the circulation. but their degradation products can be detected. Yes, the screening test of choice is preferably metanephrines or normetanephrines. It can be done in urine as well as serum. You can do either urine metanephrines or serum metanephrines or normetanephrines. The vanillin mandelic acid is not as sensitive in detecting the pheochromocytoma as the metanephrines. So preferably the urine or serum metanephrines. If not available, then we can go for the VMA values. Okay, so now coming to the statements related to that, right? Okay, propranolol is given initially to manage hypertension. How many of you agree with this statement? True or false? How many of you agree with it? No. So whenever, because these people have episodic hypertension, it needs to be controlled, but we have to initiate with the alpha blockade first. Alpha blockade followed by beta, not the beta plus. So this is not a true statement, right? This statement is false. Okay. And then what is the definitive treatment? This tumor, which is responsible for all this, has to be removed. Surgery is the treatment of choice. So option B is a true statement. Diagnosis by urine vanillin mandelic acid or catecholamines. Instead, we would prefer metanephrines, but if not available, we can consider this as well. So this is also a true statement. Can present as hypertension alone and sometimes with vomiting and pain abdomen. Vomiting and pain abdomen is primarily because of the mesenteric artery constriction resulting in the angina. So they can have pain abdomen as well. So this is also true. So the only false statement here is option A. So that will be our answer. Okay, so the same points that we discussed. Definitive treatment is surgical removal. Treatment first started with alpha blockers followed by beta blockers. Okay. Okay, so here's our next question. A 49-year-old man present with history of recurrent retrosternal chest pain with each episode lasting for 3 to 5 minutes and subsiding with sublingual nitrate. Okay, let us stick to this statement before we go further. What's your diagnosis at this level? 14-year-old, history of recurrent retrosternal chest pain, each episode lasting for 3 to 5 minutes and subsiding with sublingual nitrate. Am I dealing with stable angina, unstable angina, NSTEMI or STEMI? So how do you define stable angina? Stable angina has certain characteristics. What is it? It is characterized by retrosternal chest pain, which is appears only on exertion, not at rest. Rest angina is always unstable angina, appears only on exertion or physical activity, and even when it appears on exertion, relieved, right? Relieved under 10 minutes. In fact, today it is more stringent, even it should be relieved under 5 minutes, 10 minutes of rest or sublingual nitrates. So when these characteristics are there, only that angina will be called as stable angina, means only by exertion, and after I take rest within 10 minutes it's gone, or if I take a sublingual nitrate within 10 minutes it should be gone. So here retrosternal chest pain lasting for 3 to 5 minutes and subsiding with sublingual nitrate. So it is favoring the diagnosis of stable angina, right? So here we are dealing with stable angina. This is a case of stable angina. Now, ECG shows left ventricular hypertrophy and relatively flattened T waves. It is suggestive of presence of LVH, may be suggestive of hypertension. Flattened T may be suggestive of ischemic heart disease. Okay. Now, yes, as we expected, he is a known case of hypertension. He is also diabetic and he has elevated cholesterol parameters. He is already on aspirin, atenolol, metformin and lovastatin. So statin for his cholesterol, then metformin for his diabetes and aspirin, atenolol for his stable angina. What is the next best step in the management? Means he is already on medications for stable angina, but his angina attacks are not coming down. So what should I do? One option is increase the dose of beta blocker. Second one is injection enoxaparin. Third one is add clopidogrel. Fourth one is IV glyceryl trinitrate infusion. What do you think should be the answer here? Okay, so let us look at the okay, Kaveshri, good. So here the answer should be increasing the beta blockers. So when we are dealing with stable angina, we have to define certain problems. What are the problems that a patient of stable angina is dealing with? One of the problem is that stable angina means he already has an atherosclerotic plaque in the artery, right? So he already has, let us say his artery it is under the endothelium. Let us say this is the endothelium. Under his endothelium there is a atheromatous plaque sitting. There is an atheromatous plaque sitting that is reducing the blood flow. Because of the reduced blood flow, when he starts doing physical activity, that extra demand that his myocardium needs, it's not being met. That's why the pain appears. When he takes rest, the demand comes down. That demand we may be able to give through this narrowed artery. Okay. Now the problem is one day this atheromatous plaque will rupture. Once the plaque ruptures, platelet plug, clot formation, and then I will end up with unstable angina, NSTEMI and STEMI, right? So stable angina is associated with increased risk of progression to acute coronary syndrome, right? Second problem that these patients are facing is because of this stable angina, their quality of life is very poor, right? If I walk, let us say 50 feet, or if I climb one stair, I develop chest pain, I have angina, now I need to take rest. After rest it will come down, but I have to face that, right? So there is second problem that these patients have is recurrent anginal attacks. So as a doctor, I need to address these two problems. Means I have to reduce the risk of developing an acute coronary syndrome and I have to reduce the frequency of anginal attacks, right? So how can I decrease the risk, right? So to decrease ACS risk, what I can do? When he will develop an acute coronary syndrome? Once the plaque ruptures. Once the plaque ruptures, what is the next event? Platelets start forming in the plug. So I will give antiplatelets, right? We will give antiplatelets. So please remember, dual antiplatelet agents by guidelines are recommended after an acute coronary event for 1 year. For the prevention, dual antiplatelet agents are not recommended. We need to go ahead with single aspirin or clopidogrel. Aspirin or clopidogrel. Okay. And then second, we all know that this chance of rupturing the plaque increases as the atheromatous plaque progresses. So I will also consider adding statins. So this patient is already on statins, right? And he is already on antiplatelet. So now coming to this recurrent anginal attack, right? How can I reduce? To decrease frequency of angina attacks. How can I decrease the frequency of angina attacks? This blood vessel is narrowed, but if I dilate it, I can establish more blood flow. So his body will be able to tolerate some physical activity because his myocardium is now going to get more activity. So primarily we use vasodilators. So what I can use? Either I can use beta blockers blockers or dihydropyridine calcium channel blockers like amlodipine, right? Now the third thing is these patients will also have, despite all these medications, they can have angina attack. So when there is an attack, how do I relieve? To relieve an ongoing attack. Of course, for that I need a quick onset of action, and I can get that from the sublingual nitrates. So I can use sublingual nitrates. Now you may be thinking, sir, we can also give them oral nitrates, because oral nitrates will also cause vasodilatation and they can also help in preventing the frequency of angina attack, right? But we consider them as second line agent. Second line agents include nitrates, why am I not considering them as the first line agents? Because nitrates are not well tolerated. One of the common side effects of nitrates is it causes vasodilatation. Vasodilatation in the brain triggers headache. So headaches are a bothersome side effects many patients don't tolerate. We will not get those side effects with the beta blockers or CCBs, and especially beta blockers also decrease the heart rate, so they decrease the myocardial oxygen demand, so they are indirectly beneficial, so they are going to be preferred, right? So now you have a fair idea. Let us go back to the question and see where it fits into. Injection of enoxaparin, no. When do we use? This is an anticoagulant, right? When do we use it? If this patient had developed, right? If this patient had developed either unstable angina or NSTEMI, I would have initiated anticoagulant, right? Aspirin is already there. Dual antiplatelet agents are not required for the prevention of acute coronary syndrome in a patient with stable angina, so that's not going to be our answer. Then IV nitrates is only going to treat an attack. Here the problem is he's still having frequent attacks. So this is typically IV nitrates are typically followed when patient is hospitalized with either heart failure or acute coronary syndrome. So right answer here should be to increase the dose of beta blockers. So we can give as much as he tolerates. As much as he tolerates. So we will go ahead with increasing the dose of beta blockers. So when this question appeared in 2023 NEET PG, there were a lot of controversies. Many students are like, sir, no question aisa frame nahi tha. There was also some ECG changes, this, that. There were different versions of the question. But slowly the version that came out is this. It is basically, the story is that stable angina with angina attacks still not controlled. So I have to titrate the beta blocker dosage. That's what we are going to do for this question, this patient. Okay. Now the next question. A known case of diabetes who is non-compliant with medication presented with vomiting and abdominal pain. On examination, she was dehydrated. RBS is 500 milligrams per deciliter and ketone bodies were 2+ on dipstick. What is the next line of management? So diagnosis is very straightforward for all of us. What is going to be the diagnosis here? We are dealing with diabetic ketoacidosis. So any diabetic with blood sugar level more than 250 milligrams per deciliter and ketone bodies detectable is always a case of DK, right? So for the diagnosis of DK, how much should be the minimum blood sugar levels? So if there are like ketones positive in DM in a diabetic with RBS more than 250 milligrams per deciliter, I will take it as DKA. But if RBS in a diabetic of course, in a diabetic ketone bodies are positive but RBS is less than 250 milligrams per deciliter, this condition will be called as euglycemic DKA. Euglycemic DKA. What is the most common cause for the diabetic ketoacidosis and what is the most common cause for euglycemic DKA? Right? The most common cause for euglycemic DKA is, this is an MCQ asked recently, it is use of SGLT2 inhibitors. SGLT2 inhibitors. And the most common cause for diabetic ketoacidosis, poorly controlled diabetes. Poorly controlled diabetes, either well controlled diabetes with some intercurrent infection which triggers counter-regulatory hormones. Like when you have an infection, cortisol, adrenaline, all of that increases. These are all anti-insulin hormones. So blood glucose level increases and you end up with DKA, or it is not controlled at all. So it is poorly controlled DM. The most common cause is poorly controlled DM. Most commonly it's because of the poor compliance to medications. So here, of course, we are dealing with diabetic ketoacidosis as the diagnosis. Now we have to choose what is the management. IV fluids with long-acting insulin, IV fluids alone, IV fluids with regular insulin, or IV insulin alone. So please remember, when we have diabetic ketoacidosis, right, when we have DKA, patients with DKA have fluid deficit. Why do they have fluid deficit? Why do they have fluid deficit? So please remember, when blood glucose level becomes more than 250 milligrams per deciliter or higher, right, when blood glucose level increases, this leads to two problems. One, I am dealing with DKA, not HHS. So it leads to polyuria. Why? Because glucose, remember when we are talking about the serum osmolality, we had a formula and glucose was one of the contributor. Sodium was the main contributor. But when blood glucose level increases, osmotically active substances in the blood increase. So we start losing that glucose in the urine. With glucose, there will also be loss of water because it is an osmotically active substance. It will drain water. So we end up with polyuria, right? Polyuria results in severe dehydration. Severe dehydration. Severe dehydration. Okay. The expected fluid deficit in these patients is going to be more than 6 liter. More than 6 liters. So by the time they present to us, they already have more than 6 liters of fluid deficit, right? And then this high blood glucose level plus insulin deficiency, right? This results in free fatty acids as source of cellular energy. Now what do I mean by that? Insulin is required for the glucose to enter the cell. So when we have insulin deficiency, cells are not able to use this glucose. Your blood glucose level is high, but your cells are not able to use it. So they have to rely on free fatty acids for cellular metabolism or energy, and that results in generation of, as a byproduct of free fatty acid metabolism, we will have generation of ketone bodies, and these ketone bodies are technically acid in nature, so they cause metabolic acidosis. So there are two major problems that I am encountering when I end up with DK. One, fluid deficit. Second, metabolic acidosis, right? So when I have to treat, what all I need to do? I have to, on priority basis, correct this fluid deficit because they have more than 6 liters of fluid lost from their body. So that will be my priority, right? Second priority, if I just give them IV fluids, the problem doesn't solve because whatever fluid I give, it will be lost to polyuria if the blood glucose level is high. So second priority is get this blood glucose level under control so that polyuria comes down, and then if I start giving insulin, then instead of free fatty acids, the cells start using glucose and ketone body generation comes down, metabolic acidosis comes down. So I can get that blood glucose level down by giving insulin. So when it comes to the management of diabetic ketoacidosis, we have to remember that we need fluid, fluid resuscitation is the most important initial step. Most important initial step. And then second, to get the blood glucose under control, I need insulin. The question is what insulin I should use. Should I use long acting insulin or the short acting insulin? If I use long acting insulin, they will take their own sweet time to get the blood glucose level done, right? But I need to act actively. So I would prefer using regular or short acting insulin. Regular or short acting insulin. So insulin has to be regular, or we can also use short acting. Now when I'm using the insulin, I want to have the control because I do not want to reduce the blood glucose level too drastically, at the same time too slowly. So I need the control. I get that control when I give insulin in infusion. If I give subcutaneous, it's already in the body, right? So where my next blood glucose level is going to end, it's not in my control. But if I'm giving insulin, I can check hourly blood glucose level and titrate the dose. So this insulin has to be IV infusion, as IV infusion. Okay. Then for this metabolic acidosis, we can give the bicarbonate. Please remember, it is not routinely required, because if I get the blood glucose level properly controlled, then whatever ketone bodies are formed, they will be excreted and no more new ketone bodies will be formed. So acidosis gets reversed by itself. But when the pH is less than 6.9, we need to give the bicarbonate. So bicarbonate infusion or injection only if pH is less than or equal to 6.9. Otherwise, no need to give. This is also an important MCQ point. Okay. So what should be our answer here? I need to give fluids. I need to give insulin. Insulin has to be regular or short acting, cannot be long acting, and I need fluids. So right answer will be intravenous fluids with regular insulin. Not IV fluids with long acting, not IV fluids alone. IV fluid alone will only initially rehydrate the patient but not counter the problem. Not IV insulin alone, right? So the answer is going to be option C. There was a question in INI asking you to choose between insulin and fluid. There were separate options like IV fluid bolus, insulin bolus, insulin infusion. What should be the next immediate step? So when you recognize someone as DKA, first step is always about fluids, because when you lose 5-6 liters of fluid in your body, right, you will get into hypotension, shock, and you may die within next half an hour or 1 hour. This 400 or 500 of sugar may not kill you in next half an hour or for like 2 hours or 3 hours directly, but that fluid deficit can kill you within next 15 minutes or 30 minutes. So fluids are the priority over insulin if you have to choose. Okay, good. Next question. The fluid analysis of CSF specimen showed mononuclear cytosis. So when you say mononuclear cytosis, we are thinking about lymphocytosis. So lymphocyte predominant CSF picture with elevated proteins and low sugar, and the microscopic picture is given below. What is the most likely etiology? I think all of you should be able to quickly answer this. There's a picture, of course, showing the lymphocytosis and a test tube and some material at the bottom. So what is it? So when we have lymphocyte predominant CSF picture, what are our differential diagnosis? When we have lymphocyte predominant CSF picture, we think of viral, fungal and tubercular. One thing we can rule out. What we are ruling out? Mostly bacterial, right? So among the available options, bacterial meningitis is first thing that I can strike out, because here we are going to get neutrophil predominance. Neutrophil predominance. TB, chemical meningitis, aseptic meningitis, we may have lymphocyte predominance, right? Aseptic meningitis, viral meningitis, we can have lymphocyte predominant. What is an extra point here? Here in the bottom of the test tube, you can see some thread-like material floating, which you call it as cobweb formation. So that is one clue which is going in favor of tuberculous meningitis. There is another clue. What is that? Low sugar values. So please remember, when you have to interpret the CSF parameter quickly for the exam, I'll tell you a simple approach. What is the approach? First thing in the CSF analysis you should see is the cell count. See the cell count. If the cell count is in thousands, right, it is almost suggestive of bacterial meningitis. Means your cell count is, let us say, 5,000, 10,000, 15,000. It's always bacterial pyogenic meningitis, unlikely to be viral, tubercular or fungal. You don't see in thousands. Okay, so when it is in tens to hundreds, means like 10, 20, 30, 40, 50 or hundreds, means 300, 400, 500, 600, 800, not in terms of thousands. It could be anything, bacterial, fungal, viral, tubercular, right? So it could be bacterial, it could be viral, it could be fungal, it could be tubercular. Now how will I differentiate in that case? In such cases, the next thing you should see is the differential count. See the differential count. So if the differential count is neutrophils more than lymphocytes or neutrophil predominant, we know it is bacterial. But if it is showing lymphocyte predominant, more than 50% cells are lymphocytes, less than 50% are neutrophils, then it could be bacterial, viral or viral, fungal or tubercular. Now in such cases, what you should do is you should see the CSF glucose. You should see the CSF glucose. If the glucose is low, it is suggestive of TB meningitis. If it is normal, rarely in fungal it can be low, but for all practical purpose we will take it as normal. So if it is normal, it is either viral or fungal. We will take it as either viral or fungal. In bacterial also, bacterial will also be associated with decreased or low sugars. Sugars in bacterial will also be low. But bacterial diagnosis is very easy and straightforward. Neutrophil predominant, we know it is bacterial. So when we are dealing with lymphocyte predominant, low CSF glucose should be taken as a clue towards tubercular meningitis. Should be taken as a clue towards TB. So in this question, all the necessary clues are there. Lymphocyte predominant it is. So it is not bacterial. We have already ruled out the bacterial. But now aseptic or tubercular, low sugars are going in favor of tubercular. The 𝐒𝐄𝐈 is going in favor of tubercular. So we'll just make a list of clues that examiners give in case of meningitis, right? Clues. So if the question is talking about 𝐒𝐈 formation on the test tube, or elevated serum or elevated CSF adenosine deaminase levels, or presence of TB elsewhere in the body, like it's a known case of pulmonary TB, known case of extrapulmonary TB, now presenting with features of meningitis, think of tubercular meningitis. Okay. Second, if the clue is immunocompromised patient. When do I call it as immunocompromised patient? When it is right, HIV with CD4 count less than 200, or uncontrolled diabetic, uncontrolled DM, or if I am dealing with cancer patients or patients on immunosuppressants. We will take this as a clue towards fungal meningitis. Again, similar. Meningitis plus rash plus shock. What should I think of? Meningitis, rash, and patient is in a state of shock mainly because of adrenal hemorrhage. What should I think of? Fungal, the most common, cryptococcal. Good. What should I think of? Meningitis, rash and shock. It is bacterial, mainly meningococcal meningitis. Meningococcal meningitis. These are additional clues you should be aware of when you're dealing with the meningitis or CSF related questions. Okay. So anyway, this question was pretty simple and straightforward. All the required clues were there for us to consider this as tubercular meningitis. Okay. Now let's go to the next question. In a retropositive patient, so already question is telling that this is an HIV positive individual who is already on highly active antiretroviral therapy. The parameter used to monitor treatment efficacy is it CD4 T cell count, is it P24 antigen, is it viral load, or is it viral serotype? What is the parameter used to assess whether the treatment is working well for the patient or not? What is the current NACO guideline suggesting? Good, very good. Okay, so what are the indications for ART in HIV? Should we start the ART for all HIV positive individuals, or there are selected indications? Is it for all, or there are selected indications? Okay, so please remember, currently there are no selective indications, but for all HIV positive individuals. So in the past, what we used to do is we used to start the ART once the CD4 count is dropped below 250. But by doing so, already patient's immune system is compromised. He would have started developing the opportunistic infections. So now we start the day we make a diagnosis. Once the renal functions, liver functions are all fine, we start. Right? It is for all immediately. We are not wasting the time. Okay. Now, some of you might have heard of a complication called as iris. When we start the ART, people can develop iris. And one of the major component of iris is reactivation of tuberculosis. So now the guidelines recommend that we should give the prophylaxis for tuberculosis. So what is the drug of choice for TB prophylaxis in HIV? What is the drug of choice for TB prophylaxis in HIV? The NACO guidelines recommend INH prophylaxis for all patients with HIV. Right? So we start INH so that if there is latent TB, it is taken care of, right? And then we initiate the ART. Okay. So, and once we initiate the ART, we no longer follow the CD4 count to assess whether the patient is responding to treatment or not. Right? Yes. First ATT followed by ART. The current recommendation is that we should follow the viral load, right? The goal is undetectable viral load. Suppress the viral load as low as possible. The lower the viral load, lesser the impact on the immune system, lesser the impact on the CD4 cells, right? Lesser the chance of developing complications. So with today's advanced heart medications, the people with HIV are able to live almost normal life. Okay. That 2 weeks, Karthik, 2 weeks is not a rigid guideline. Depending on patient's CD4 count, we can start at 2 weeks, or sometimes we might have to start much later as well. But at least remember for the exams, if I have to start the antitubercular therapy in a patient with HIV, I should start ATT first, followed by ART to prevent immune reconstitution inflammatory syndrome. Okay. Next question. What is the drug of choice for acute management of unilateral headache associated with nausea, photophobia, phonophobia in female patients? Pretty simple, straightforward question, right? So what is the diagnosis here? All the clues there, no confusion, nothing there. It's a classical case of migraine. I'm not saying classical migraine because there is no talk about presence of aura. That story is classical of migraine, right? It's migraine, no description of aura, so we would consider it as Sangeeta Reddy, iris refers to immune reconstitution inflammatory syndrome. So it is a complication because when you have HIV, so HIV results in decrease in your CD4 count. So your immune system is quite poor. So this CD4 count decrease of course leads to development of infections, let us say TB. So patient is now affected, or like in India we are already exposed to TB, it gets reactivated. Latent TB has now got reactivated. But patients will not have any symptoms, may not have symptoms because symptoms are because of inflammation. Right? When infection happens, significant number of symptoms are because of inflammation. That inflammatory response is blunted because of the impaired immune system. Now in this patient, when I start giving the ART, when I introduce the ART to this patient, the CD4 count starts improving, right? Now this TB, which was not having inflammatory symptoms, now that the immune system improved, I will start mounting an inflammatory response to the presence of TB bacteria now. Earlier my inflammatory response was suppressed, but now it bounces back. It bounces back with much more vigor, causes severe organ inflammation. That severe organ inflammation can even lead to death. So this complication of immune, it's called as immune reconstitution, means immune system was suppressed, now it is reconstituted. Reconstitution resulted in development of severe inflammation. That's why it is called as immune reconstitution inflammatory syndrome. Now fearing this complication, I cannot stop giving the antiretroviral therapy, right? So what I will do in such cases, before I make the immune system reactivated, first treat the infection, right? Get the TB under control. Once the TB comes under control, the TB bacilli are less. After that, I will reactivate my immune system by treating the HIV. Now, immune system is not going to cause severe inflammation because the antigens that are triggering the immunity, triggering the inflammation are already reduced by reducing the TB bacteria. So that's why first ATT, reduce the burden of the tubercle bacilli and then start the ART. Okay, so here we are dealing with migraine. So what is the drug of choice for migraine? The drug of choice for migraine is sumatriptan, right, for the acute treatment. And for the preventive treatment, it is going to be beta blockers like propranolol. Propranolol for the preventive treatment. It's a drug of choice for preventive treatment. So the question is asking about the acute management. So we are going with sumatriptan. If they are talking about the preventive treatment, then we would have gone ahead with propranolol. Topiramate and flunarizine are also FDA approved for the treatment of the migraine as preventive treatment. So they are all for preventive treatment. Among them, the drug of choice is propranolol. Sumatriptan is of course the drug of choice for acute treatment. Okay. Now let's go to the next question. A patient was brought by relatives with sudden onset breathlessness. He is a known case of hypertension who is non-compliant with medication. On chest X-ray, the picture is as shown below. What is the next line of management? Sudden onset shortness of breath is a known case of hypertension. Not taking medication properly. Chest X-ray is shown below. So what do you notice on the chest X-ray? What do you notice on the chest X-ray? Chest X-ray is showing a classical pulmonary edema, right? Bilateral bat wing distribution of the opacity. So it's a classical pulmonary edema. A known hypertensive developing sudden onset pulmonary edema. So what is your diagnosis? So the diagnosis here is left ventricular failure or acute heart failure, right? So diagnosis here is acute left ventricular failure. In other words, acute heart failure. Okay. Now before we discuss more on this, Can anybody tell me a patient with hypertension is likely to develop which kind of heart failure? Heart failure can be classified as heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. So if I am hypertensive, I am likely to develop heart failure with preserved ejection fraction or heart failure with reduced ejection fraction. Yes, it is cardiogenic pulmonary edema. We are thinking of heart failure. So as you know, heart failure can be classified as heart failure with reduced ejection fraction when the ejection fraction of the patient is less than 40%. So when EF is less than 40%, we call it as heart failure with reduced ejection fraction, and when the ejection fraction is more than 50%, more than or equal to 50%, we will call it as heart failure with preserved ejection fraction. When EF is 50 to like more than or equal to 50%, ejection fraction more than or equal to 50%, we call it as heart failure with preserved ejection fraction. If the EF falls between these values, we will call it as heart failure with mid-range ejection fraction. Heart failure with mid-range ejection fraction, right? So the most common cause for heart failure with preserved ejection fraction is hypertension. And the most common, see, please remember, heart failure with reduced ejection fraction is where the force of contraction of the heart has come down. When the force of contraction of the heart will come down? When the blood supply to the myocardium is compromised, the myocardium is not able to contract. So the most common cause for the heart failure with reduced ejection fraction is ischemic heart disease. And here, because the left ventricle is not able to contract, when it contracts during systole, so this is primarily systolic heart failure. It is systolic heart failure. Heart failure with reduced ejection fraction is systolic heart failure. In case of heart failure with preserved ejection fraction, the contraction is good, that's why ejection fraction is good. It is not able to relax well during the diastole, so it is not able to fill well. So it is a diastolic heart failure. Diastolic heart failure. So if I am getting this kind of a picture, like someone with hypertension, BP shoots up and he ends up with left ventricular failure, I am thinking of heart failure with preserved ejection fraction. Okay. So here ischemic heart disease, in acute MI, chronic ischemic heart disease will present with chronic heart failure, right? Hypertension is the most common cause for heart failure with preserved ejection fraction. Now here we have developed heart failure, that too acute. How will I treat? What is the problem here? Heart is now having the burden of the blood, right? Heart is not able to distribute the blood. The pressure in the ventricle eventually builds up in the atria, pressure builds up in the pulmonary veins, and the pressure in the pulmonary capillary is building up, resulting in the pulmonary edema. So how can I ease this patient's problem? So let us say that I have developed this acute heart failure. So systolic or diastolic, I am eventually not able to eject the blood forward easily. So pressure starts building up in the left ventricle, left atrium. Eventually the pressure will build up in the pulmonary veins. Pulmonary veins, as we know, they are going to the lungs. So we have pulmonary capillaries. So pressure starts building up everywhere in the pulmonary veins, pulmonary capillaries, and from the pulmonary capillaries, because of this pressure build up, the fluid starts leaking into the alveoli, and this is what we call as pulmonary edema. Now how can I ease this patient's problem? In hypertension, let us take the example of hypertension itself. Okay, why the pressure is building up more into the left heart and eventually to the pulmonary capillaries? Because the forward flow of blood is getting impaired by what? Impaired by high blood pressure. Why? Because high blood pressure means vasoconstriction, right? You have increased activity of RAS. RAS has angiotensin 2, which causes vasoconstriction. So all of your peripheral blood vessels, like let us say this goes aorta goes and gives out these peripheral blood vessels, they are all constricted, right? So blood going forward is getting impaired, pressure is building up in the heart. Now if I cause vasodilatation here, I facilitate easy pooling or forward flow of blood, because basically the physics says fluid moves from higher pressure to lower pressure, and as Boyle's law says, pressure is inversely proportionate to volume. So if I cause vasodilatation here, right, I dilate these peripheral blood vessels, what happened to the volume? Volume increased. That means pressure here decreased. So if I decrease the pressure in the peripheral blood vessel, it becomes easy for the heart to forward flow the blood towards the peripheries. So the burden on the heart comes down, burden which is now like pressure piling up behind all starts coming down, the pulmonary edema starts getting eased. So I can do those, like I can give vasodilators which can ease the heart. Second, all this congestion is because of blood, right? So what if I reduce the volume of the blood? The congestion will also come down. So I can use diuretics as well as vasodilators, which play an important role in acute heart failure. So now let us go back and see the options and choose the one. What can be the right answer here? Oxygen and antibiotics is not the answer, because we are not thinking of pneumonia, right? That's not answer. Intravenous salbutamol, no, the salbutamol being a sympathomimetic, it will increase the heart rate, worsen the patient's condition, right? That's not our answer. Nebulization with salbutamol, no, we are not dealing with an asthma attack, we are dealing with a heart failure. So intravenous nitroglycerin, it's a vasodilator. By causing the vasodilatation, it eases the blood flow from heart to the peripheries and helps. Yes, we can definitely use. If the option was loop diuretic, I would have gone ahead with loop diuretics as well. So B will be our answer of choice here. In addition, if the BP is high, that will also be lowered with the help of this nitroglycerin. Okay, now let's go to the next question. A woman in her 30s presented with fever associated with night sweats. On examination, ptosis and bilateral facial nerve palsy was found. Investigation showed leukocytosis and bilateral hilar lymphadenopathy. What is the most likely diagnosis? What do you think should be the diagnosis here? What do you think should be the diagnosis here? Now we all are conditioned to believe that whenever there is night sweats or evening rise of temperatures, we always think about tuberculosis, right? TB is a possibility. But then there is a closely related differential diagnosis to tuberculosis, behaves similar to TB on several ways, that is sarcoidosis. So I have to think of these two conditions here, right? I'm not thinking of lymphoma or hypersensitivity pneumonitis, because they cannot explain the other findings. Lymphoma may explain fever, night sweat, but cannot explain the ptosis, bilateral facial palsy. Now I have to choose between TB and sarcoidosis. Ideally speaking, what is the diagnostic criteria for sarcoidosis says? We make the diagnosis of sarcoidosis after TB is ruled out. TB has to be ruled out by a negative, like IGRA, the quantiferon gold, or other investigations. Once the TB is ruled out, then we start thinking of the sarcoidosis. But in the question, there are other pointers which make me strongly think that it is sarcoidosis. What is that? Sarcoidosis is typical in middle-aged. TB has no age predilection, right? So that is one. Then sarcoidosis is more common in females. TB has no predilection. It is more common in females than males. It is typically more common in middle-aged. So the demography is leaning towards sarcoidosis. Okay. Then tuberculosis can cause the third nerve palsy. It can cause the seventh nerve palsy because of the development of like the raised intracranial tension as false localizing signs. Sometimes the basal exudates can cause cranial nerve palsy, but getting this bilateral facial nerve palsy, which is not very usual in the tuberculosis. You may get unilateral. That is also favoring the diagnosis of sarcoidosis. Okay. So facial palsy is going in favor of sarcoidosis. That to here being bilateral. Now, can anybody tell me why do we get facial palsy in sarcoidosis? Why do we get facial palsy in sarcoidosis? Because sarcoidosis is a granulomatous inflammation just like TB. The difference is in TB we have caseating granulomas, and in case of sarcoidosis we have non-caseating granulomatous inflammation. Okay, and those caseating granulomatous inflammation does affect the parotid gland, and there is swelling of the parotid gland, and because we have close anatomical relationship with the facial nerve often gets compressed, resulting in facial palsy. Many times facial nerve also gets affected by the inflammation. Okay, so in fact in sarcoidosis the most commonly affected cranial nerve is facial nerve, and that is the most common nervous system manifestation, and the second most commonly affected cranial nerve is the third cranial nerve, which may explain why there is ptosis. So taking those points in favor, we will go ahead with sarcoidosis. But again, I am reiterating, please remember, in practice we come to the diagnosis of sarcoidosis only after ruling out tuberculosis. That's a basic diagnostic criteria for sarcoidosis. So again, in the exam, clues for sarcoidosis, we will just make a small slide. Clues for sarcoidosis. This is not the clue for clinical practice, but the clue for MCQs. The first one is increased angiotensin converting enzyme levels, ACE levels, which is seen in sarcoidosis. Because ACE is produced by the lungs, and when sarcoidosis affects the lungs, the inflammation of the lungs make us leak the ACE from the lung cells into the circulation. Okay. Second clue is in the form of hypercalcemia plus, please remember this is a very important point, hypocalciuria. Sorry, hypercalcemia and hypercalciuria. Normally when we have hyperparathyroidism, we will have hypercalcemia and hypocalciuria, but in sarcoidosis both hyper. Third clue is facial nerve involvement. Of course, you are familiar with the Garland sign, lambda sign, panda sign. Those all radiological clues can be there. Clinical clues, mainly elevated AC levels, or if the question says patient has got hypercalcemia, hypercalciuria, or there is also discussion of facial nerve involvement. So in this case, there was discussion of facial nerve involvement, bilateral hilar lymphadenopathy, and fever. Okay. Now let's look at the next question. A CT scan of a woman who is 37-year-old presented with fever, breathlessness, and cough with expectoration. And the CT scan is here. What is the most likely diagnosis? So what do we notice in the CT scan? I want you to pay attention to this area. What do you notice? There is an opacity. Okay. Now, are you able to make out this black line, tree-like branch? So what is it suggestive of? Yeah. What is it suggestive of? So here you can see a opacity on the HRCT, and along with that opacity could be because of the collection of thick pus, it can be because of collapsed lung, but then you notice one important finding here. What do we call it as? We call it as air bronchogram. Air bronchogram. And what air bronchogram indicates? Consolidation of the lung, right? Consolidation of the lung. Air bronchogram is equal to lung consolidation. It's equal to consolidation. Consolidation most commonly happens, solidification of the lung most commonly happens because of pneumonia. Because of pneumonia. Most commonly because of pneumonia. So now everything fits into pneumonia, right? Like patient has got fever. Consultation can happen because of the collapse of the lung also, but then of course you will not have the fever and expectoration. So taking into account the context and the evidence of consultation on the HRCT, what is our diagnosis? The diagnosis is we are dealing with pneumonia. So if that is my diagnosis, what should be the what should be my answer here? Of course, consultation with air bronchogram. And how do I treat this patient now? What will be my next step if I get this patient? I will apply the curve 65. Based on that, I will decide whether the patient goes to outpatient or inpatient or ICU, and I have to choose appropriate antibiotics. Okay, good. Okay, can anybody tell me where else you get this wedge-shaped opacity? Without, of course, without the air bronchogram. Wedge-shaped opacity. I'll give you the context. Air travel, followed by that patient presented with shortness of breath, and you get a wedge-shaped opacity on the X-ray or HRCT. What would you think of? I'm giving you a lot of context. Patient had a long distance flight. Okay. After that, he presented with shortness of breath, maybe a swelling of the leg as well. And on the HRCT, you are getting a wedge-shaped opacity. The whole story is suggestive of patient developing a DVT and pulmonary embolism. So when you develop pulmonary embolism, we can get a wedge-shaped infarct with a base towards the pleura and the tip directed towards the hilum, right? We should think of pulmonary embolism. Okay. Let's go to the next question now. A patient who ingested 10 tablets of paracetamol, how much each tablet was weighing not mentioned, and he was brought to emergency department. He has developed oliguria and liver function tests show deranged values. Which of the following can be used in the management of this condition, right? I think all of you are familiar that drug of choice or the antidote for paracetamol poisoning is N-acetylcysteine. That's not what I want to address here. I am sure you all know. The point is, let us say that I got a patient who has taken paracetamol. He has not developed any complications as of now. He has come to me. Should I give N-acetylcysteine to all patients or selected patients? All or selected patients? Antidote for PCT poisoning. N-acetylcysteine, NAC. If NAC is not available, can there be an alternative? Of course, NAC is more readily available than the alternative, but if examiner want to ask, you can say S-adenosyl methionine or SAM. SAM can be considered as an alternative to NAC, but NAC is the one which is more readily available. Now it is available even over the counter as lung protective supplement and all. Literally abuse it is. Now it is not indicated for all patients because all patients might not have taken the toxic doses. So then it is of course indicated for selected patients, but then how do I decide that who should be given the N-acetylcysteine? So decision to give N-acetylcysteine is based on which parameter? So it is based on when the patient presented and how much paracetamol he has taken. But of course, it's not based on the patient's history. History is not reliable. When someone has an intention to commit suicide, he may give you a falsified history. And when someone wants to just scare the family members and has taken 1 or 2 tablets, he may again give a falsified history. So we rely on the blood paracetamol levels. So time after consumption and the blood paracetamol levels, we will plot it on a graph and we call this graph as 𝐒𝐬𝐃 nomogram, right? So decision to treat with NAC is based on this plot called as 𝐒𝐬𝐃 nomogram. 𝐒𝐬𝐃 nomogram. So what is there in this 𝐒𝐬𝐃 nomogram? Time and serum paracetamol values. So when patient consumes paracetamol, anytime after 4 hours we can check his blood levels. If he comes 4 hours or later, we can check the blood levels. If he has come before that, we will not check the blood paracetamol levels. Why we will not check if he has come within 4 hours? Like I took now and I reach you in 1 hour. You will not check my blood paracetamol levels. Why? Because whatever I have taken, for it to completely absorb and for me to reach the peak blood levels, it takes 4 hours. The therapeutic doses, the peak is reached within 2 hours, but toxic doses, it can reach by 4 hours. So I want to know the peak blood levels, which I can only get to know 4 hours after patient has consumed it. So that's why at 4 hours or anytime later, we can check. And we will plot that serum paracetamol values on this time graph. And this nomogram, as you look at it, there are 2 lines drawn. One line is called as the treatment line, and there is on top of it another line which is called as toxicity line. So from studies, we already know that any paracetamol value which falls above this toxicity line has high chances of developing the toxicity, and we know paracetamol primarily causes liver dysfunction. So high chances of liver failure if the blood values plotted according to time fall above this toxicity line. But if I only treat those values which are above toxicity line, then I may miss out on treating some which may have still reasonable risk of the toxicity. So we have reduced, what we have done is, we have reduced the values by 25%. So let us say that at 4 hours, you can develop the liver failure if the serum paracetamol value is 200 micrograms per ml. We will reduce it by 25% and we will instead treat it at 150 only. We don't want to think of treating only when 200 it is, because 200 is associated with toxicity. I will keep the treatment line little lower. How lower it is? 25% lower. So at 4 hours, 200 is associated with toxicity. But if at 4 hours, if I find 150 also, I will start treatment. So treatment line is set at 25% lower paracetamol values compared to the actual toxicity line, right? So any value which falls above the treatment line, we initiate the N-acetylcysteine. So if the patient's paracetamol values are below this treatment line, then we will not start them on the N-acetylcysteine. We will only give the supportive treatment. Okay. So the point to remember about paracetamol poisoning: there is an alternative to N-acetylcysteine. If N-acetylcysteine is not accessible, S-adenosylmethionine can be used, and the decision to give or not is based on the 𝐒𝐬𝐃 nomogram. Okay. Next, an MRI scan of a non-pregnant female with complaints of galactorrhea revealed a large pituitary tumor who is not willing for surgery. Which of the following is the best drug for treatment? Galactorrhea, and patient is non-pregnant, large pituitary tumor. What's your diagnosis? Of course, the diagnosis here, we are dealing with a pituitary adenoma. Because they have used the term large, I am considering it as macroadenoma, right? So we are primarily dealing with a pituitary adenoma. With galactorrhea, I will think of prolactinoma, right? We are dealing with prolactinoma, mostly macro because I've used the term large. Okay, so when do we call it as macro? If there is a pituitary adenoma whose size is less than, maximum diameter is less than 1 centimeter square, we will call it as microadenoma. If it is prolactinoma, you can call it as microprolactinoma, right? If it is more than 1 centimeter square up to 4 centimeter square, we will call it as macroadenoma. And if it is more than 4 centimeters square, it will be called as giant adenoma or a giant prolactinoma if it is prolactinoma. What is the treatment of choice for prolactinoma? Of course, dopamine agonist, because we know that dopamine has an inhibitory action on the prolactin secreting cells, not just in secretion but also their proliferation. So it decreases the cell size, decreases prolactin release both. So tumors shrink, prolactin release also comes down. So the treatment of choice is dopamine agonist like cabergoline, bromocriptine. But what if there is a macroadenoma or giant adenoma? What will be the treatment of choice? Micro, okay, let us say we will give the drugs. If it is macro, if patient presents with, let us say, bitemporal hemianopia, should I give it drugs or go ahead with surgery? What if he comes with giant prolactinoma, 4 centimeter? Should I go with surgery or drugs? So please remember, no matter what the circumstances, prolactinomas have excellent response to dopamine agonist, and the mainstay of treatment will still remain dopamine agonist because it shrinks. Tumors generally shrink. Only under 2 conditions we go for surgery. What are the 2 conditions? One of them is failure of dopamine agonist. I give cabergoline or bromocriptine and it fails to shrink the tumor, I have to go for surgery. The second one is when you're dealing with pregnancy where the tumor tends to increase in size, you may consider preemptively going for surgery if you're planning for pregnancy. Otherwise, the mainstay of treatment will always remember, regardless of the size of the tumor, will be the dopamine agonist, right? So here that context of not willing for surgery doesn't come into picture if I'm dealing with prolactinoma. I should not even be counseling them, right? Only when my dopamine agonist fail, I should be. So now I have choices of bromocriptine and cabergoline as dopamine agonist. Octreotide can be helpful. Clozapine is not useful. Promethazine is not useful. Octreotide can be considered as one of the second line agents. Bromocriptine is the drug of choice, which is technically what it is, dopamine agonist. Can anybody tell me how octreotide can be helpful for a prolactinoma? But again, it is drug of choice in pregnancy or for patients with anticipated pregnancy. Otherwise, what do we prefer? Otherwise, we would prefer cabergoline because it is long acting, it is more effective than bromocriptine. But studies are not there about the safety of the cabergoline, not in large scale as much as it is available for bromocriptine for the pregnancy. That's why for pregnancy, we can think of bromocriptine. Otherwise, cabergoline is the best drug when it comes to pituitary prolactinomas. Okay. So how octreotide helps? Please remember, both the prolactin secreting cells and growth hormone secreting cells, they are derived from the same stem cell. They share a lot of characteristics. Even prolactin and growth hormone have structural similarity. Lot of amino acid sequences are very similar. Prolactin can stimulate growth hormone receptors. Growth hormone can stimulate prolactin receptors. So they are like like I wouldn't call twins, but they are literally siblings. So even prolactin producing cells express the somatostatin receptors. Somatostatin can suppress the prolactin producing cells activity. So octreotide can be used. Similarly, the dopamine agonist, the cabergoline, bromocriptine can be used as an adjuvant for treatment of growth hormone secreting tumors. So Naman, reduce the size and then go for surgery is primarily followed for the growth hormone producing tumors, somatotropinomas, not for the prolactin producing tumors. Prolactin producing tumors show excellent response to the dopamine agonists. Okay, yes, they're both are acidophil cells. They are derived from the acidophil stem cells. Okay, so option A will be our answer for this question. Okay, now let's go to the next question. Question is on JVP findings in patients presenting with an irregular pulse and a pulse deficit of 20. Pulse deficit of 20 and irregular pulse. So what is it suggestive of? I think we have discussed a question on this. It is suggestive of atrial fibrillation. Diagnosis is atrial fibrillation. Irregular pulse and a pulse deficit of 20. So what do we expect in the JVP of a patient with atrial fibrillation? JVP of a patient with atrial fibrillation is expected to show that we know that in atrial fibrillation, atria is not contracting. When atria is not contracting, the A wave is produced by atrial contraction. So if atria doesn't contract, right, if the atria does not contract, there is no formation of A wave at all. So we all know that in atrial fibrillation, we get absent A waves. We get absent A waves. Of course, we will also have absent P wave in atrial fibrillation, but that's ECG finding, not JVP finding, right? It's an ECG finding, not the JVP finding. Where do we get Canon A waves? Canon A waves refers to intermittent tall A waves. Intermittent tall A waves classically seen when there is AV dissociation. Intermittent tall A waves classically seen when there is AV dissociation. In AV dissociation. What do you mean by AV dissociation? Separation of atrial and ventricular activity. In other words, having different rates. Atrial rate is different from ventricular rate. Either atrial rate is more than ventricular rate. When I get atrial rate more than ventricular rate, mainly I get that when we have complete heart block or third degree AV block. And when do I get ventricular rate more than atrial rate? When I have ventricular tachycardia or ventricular fibrillation or ventricular ectopics. Ventricular ectopics. These conditions we call it as having AV dissociation. And when we have AV dissociation, we get this Canon A wave. Raised JVP with normal waveform. Raised JVP with normal waveform. So, right atrial pressure constantly elevated can give rise to elevated or like prominent A waves. We can have the tall X descent, but I cannot say that there is one pathology where you will have only JVP raised but all the waveform appears normal. You can have raised JVP with no waveform, not normal waveform, no waveform when there is a superior vena cava compression. Superior vena cava compression. In hyperdynamic circulation, yes, you can have the prominent, all the waves becoming prominent. Yeah. Okay, so here's our next question. A chronic liver disease patient, CLD or cirrhosis patient presented with abdominal distension, jaundice and pruritus. Ascitic fluid analysis revealed neutrophil count of more than 650 ml per cubic millimeter. What is the most likely diagnosis? So I think diagnosis is straightforward, but there is one MCQ point to learn here. So what are we dealing with? We are dealing with a case of CLD, chronic liver disease or cirrhosis of liver, with abdominal distension, jaundice and pruritus. So what does that indicate? If he has already developed abdominal distension, that means he has developed ascites. There is a picture also given. So that means there is portal hypertension. Portal hypertension. With portal hypertension, he also has jaundice and pruritus. So what does that indicate? It indicates hepatocellular failure. Hepatocellular failure. So both portal hypertension as well as hepatocellular failure is there. So what should I label it as? When jaundice appears, we start labeling it as decompensated. We are dealing with decompensated chronic liver disease, DCLD or decompensated CLD. Now, patients with ascites and portal hypertension are at increased risk of developing various complications like hepatorenal syndrome, and one such complication is called as spontaneous bacterial peritonitis. Spontaneous bacterial peritonitis. Now, how do I diagnose this spontaneous bacterial peritonitis? SBP or spontaneous bacterial peritonitis. When should you suspect? For the diagnosis, what I need is, I need a patient with cirrhosis of liver, presenting with ascites, and in that ascitic fluid, if I get that increase neutrophils or polymorphonuclear cell count more than 250 per cubic millimeter. This is a learning point. If there is more than 250 ppms per cubic millimeter on the ascitic fluid, then we make the diagnosis of spontaneous bacterial peritonitis. So how much I am getting here? I am getting 650. It is definitely more than polymorphonuclear cell count more than 250. So it is suggestive of spontaneous bacterial peritonitis. So this is a case of CLD with portal hypertension with the liver cell failure with spontaneous bacterial peritonitis. So I am going ahead with the diagnosis of spontaneous bacterial peritonitis. That's my answer. It's not going to be tubercular ascites, malignant ascites, or intestinal obstruction. Now, what is the cause for this spontaneous bacterial peritonitis? What causes it? Why a patient with CLD develops spontaneous bacterial peritonitis? The main reason for someone to develop spontaneous bacterial peritonitis is translocation of intestinal bacteria into ascitic fluid. So bacteria that are there in the intestine, they may be in commensals in the intestine, but once they enter into the ascitic fluid, they are pathogenic. So from the intestine, there is transmigration of these bacteria to go into the ascitic fluid. So what could be the most common organism responsible in that case? Most common organism responsible for spontaneous bacterial peritonitis. What is the most common organism in intestines? It is E. coli, right? So E. coli is the most common organism responsible for spontaneous bacterial peritonitis. So when someone develops it, I have to treat with antibiotics, right? And what is the antibiotic of choice in that case? Antibiotic of choice in that case, the antibiotic of choice is going to be third generation cephalosporins, which generally work well for the E. coli. Third generation cephalosporins like ceftriaxone. Along with that, we might need to give albumin, because lower the albumin, higher the chance of developing spontaneous bacterial peritonitis. So we might have to also consider giving albumin. So if the question says that there is someone who presented with known CLD, presented with ascitic fluid neutrophil count more than 250, we are dealing with spontaneous bacterial peritonitis, they may ask you what is the drug of choice. In that case, go ahead with ceftriaxone or any third generation cephalosporin available in the options. Okay. So now let's go to the next question. A patient presented with yellowish discoloration of skin and sclera. On evaluation, bilirubin and ALK phos are elevated. Remaining liver enzymes are in normal range. What is the likely diagnosis? So what do you think here? This is a very simple question. Hepatic jaundice, hemolytic jaundice, obstructive jaundice, prehepatic jaundice. Many times this term is used and then story is built on it for you to reach a higher level of diagnosis. Yellowish discoloration, that means there is jaundice, right? And of course mention that there is elevated bilirubin and ALK phos. Other liver enzymes means SGOT, SGPT are normal. So how do you approach this? So Harrison gives a very beautiful algorithm, very simple but useful algorithm for approach to jaundice. And I think I have taken a class on the Telegram as well for the Sankalp group for approach to jaundice. So whenever you are dealing with a case of jaundice, what is the first thing you should see is whether it is only isolated elevation in the bilirubin or bilirubin plus other enzymes are abnormal, right? So if you are dealing with, let us say, jaundice, if you are dealing with jaundice, that is high bilirubin, if only bilirubin is elevated, or bilirubin plus other enzymes are also elevated or abnormal. If only bilirubin is elevated, for the exam going student, only think of inherited hyperbilirubinemias. If SGOT, SGPT, ALK-Phos are normal. So when I say only bilirubin elevated means I am talking about direct, indirect being altered, but SGOT, SGPT and ALK-Phos are normal. So in that case, think of inherited hyperbilirubinemias, for which you know the conditions, like you have this Dubin-Johnson's, and Rotor, and then you have Crigler-Najjar and Gilbert. Crigler-Najjar and Gilbert. So if it is only bilirubin elevated, think only of these conditions. And in case of Dubin-Johnson and Rotor, it is the indirect predominant hyperbilirubinemia. And in case of Crigler-Najjar and in case of the Dubin-Johnson and Rotor, it is the direct predominant hyperbilirubinemia that you are getting. And in case of the Crigler-Najjar and Gilbert, you are getting indirect predominant hyperbilirubinemia. I will make it easy for you to remember. Dubin-Johnson, just remember direct. So even Dubin-Johnson, you have direct hyperbilirubinemia. Direct hyperbilirubinemia. And Crigler-Najjar you can remember with a mnemonic CGI. Mnemonic CGI means in Crigler-Najjar and Gilbert you have indirect hyperbilirubinemia. Indirect hyperbilirubinemia, where in Crigler-Najjar and Gilbert you have indirect hyperbilirubinemia. That kind of sorts out when bilirubin levels are only increased. SGOT, SGPT, ALK-Phos is normal. That means SGOT, SGPT, ALK-Phos are normal. So here bilirubin plus either SGOT, SGPT or ALK-Phos is altered. Now how will I approach here, right? So please note down. So when you're dealing with this bilirubin and other enzymes being abnormal, okay, so if ALK-Phos is predominantly elevated, means more elevated than, what does that indicate? And if the SGOT, SGPT, which are nothing but ALT, AST, they are predominantly elevated. So if ALK-Phos is more elevated, out of proportion elevated in comparison to SGOT, SGPT, it is suggestive of obstructive jaundice. Obstructive jaundice. And if AST, ALT are more elevated in comparison to ALK-Phos, it is suggestive of hepatocellular jaundice. Hepatocellular jaundice. So this is how we get to know whether I should be suspecting and evaluating for an obstruction. If an obstruction is suspected, I should go for ultrasound, maybe MRCP. And if I'm suspecting hepatocellular jaundice, I should think of liver injury like paracetamol-induced injury, viral hepatitis, acute, chronic, drug-induced liver injury and all that, right? So let's get back to this question now. What is the pointer here? Jaundice is present, right? But of course, there is also ALK-Phos elevated. So should I think of Crigler-Najjar or other conditions here? No, I should think of inherited hyperbilirubinemias only when bilirubin isolated elevation is there, enzymes are abnormal. But here enzyme is abnormal, enzymes are not normal, right? ALK-Phos is elevated. So bilirubin is high, but not isolated elevation in bilirubin, but there is also increase in ALK-Phos. But there is normal AST, ALT. So what should I think according to this algorithm? I should think of obstructive jaundice. If AST, ALT were mainly elevated, I should thought of hepatocellular jaundice. So it is not hepatocellular jaundice, because in hepatocellular jaundice there will be rise in AST or ALT or both. Okay, so what I should strongly think of? I should think of obstructive jaundice. So our answer here is going to be obstructive jaundice, looking at the ALK phos elevation. Okay, so let's go to the next question now. A male patient presented with weakness. Drug history of diuretics intake is present. ECG showed flat T waves and prominent U waves. What is the most likely diagnosis? So earlier we were talking about it, right? Like when you think of brain and electrolytes, think of sodium. When you think of heart and electrolyte, first thing you should think of is potassium, right? Of course, calcium also has the ECG changes that we can get. So what electrolyte abnormality can give rise to flattened T waves and prominent U waves? Is it hyperkalemia, hypokalemia, hypomagnesemia, or hypernatremia? Sodium has minimal or negligible, no impact on the ECG at all. So comfortably, one thing that I can rule out here is hypernatremia. Hyperkalemia, hypokalemia, hypomagnesemia. The moment you see, like you see tall tented U waves, you think of hyperkalemia. Similarly, U waves, primarily you should think of hypokalemia. You should think of hypokalemia. So what are the ECG changes we get in hypokalemia? Some of them are exactly opposite of hyperkalemia. Okay. So in hyperkalemia, the PR interval becomes shortened. Hyperkalemia, what are the ECG changes we get? One of the ECG change we get is short PR interval. Here we get prolonged PR interval. So in hypokalemia, I am getting prolonged PR interval. When do I call it as prolonged PR interval? When PR interval is more than 200 milliseconds. Normal PR interval is 120 to 200 milliseconds. So the PR interval starts from the beginning of P waves and ends with the beginning of the QRS complex. It is becoming prolonged. It is becoming more than 200 milliseconds. Okay. Then second, here you can have ST depression. In hypokalemia, you can have ST depression. Third, you can have QT prolongation. So corrected QT interval or QTC is usually prolonged. Okay. Then with respect to T waves, in case of hyperkalemia, we see tall tented T waves. So here we get flattened T waves, opposite of it, right? We get flat T waves. Okay. And in addition, you may have prominence or emergence of U wave. Prominent U wave. So please use this prominent U wave as a potential clue for the hypokalemia. Flat T wave and U wave. Okay. One important MCQ point, not very common but sometimes may be seen. What happens in the hyperkalemia? Eventually you see something called as sine wave, right? So here, as the potassium levels go on increasing, the P wave goes on becoming shorter in hyperkalemia, smaller and eventually disappears, and only QRS, which is becoming wide. So in hyperkalemia, you have widening of the QRS, and then you have small P waves which may become absent or which may become absent. So eventually when P waves become absent and QRS has become wide, we have ended up with what we call as sine wave. Sine wave appearance. You only have QRS, no P wave, and that too wide QRS. We call it as sine wave. That's the last thing. More severe hyperkalemia. Here the P wave is becoming small, eventually become absent. Here ulta can happen, opposite of it. You can have tall P wave. And the tall P wave here, we are not getting, normally where do we get tall P wave? Can anybody tell me where we get tall P wave? Tall waves are classically seen in P, we call it as P pulmonale, right? Where do we see? When we have right atrial hypertrophy. But here we are getting P pulmonale kind of picture, tall P wave without right atrial hypertrophy. So we call this as pseudo P pulmonale. It is called as pseudo P pulmonale. Ideally, when we have right atrial enlargement, we get tall P waves. Here we are getting without right atrial enlargement, so we call it as pseudo P pulmonale. Right? So you can have this tall P waves, we will call it as pseudo P pulmonale. In hyperkalemia, that P wave become stunted. Okay, so here our answer is going to be, of course, hypokalemia. Now, this is the next question. A patient brought to emergency department, ABG shows pH of 7.3, PaCO2 of 79, bicarb of 39. Which of the following is the most likely diagnosis? So pH is 7.3, so we already know acidosis. So two alkalosis options are ruled out. So we are dealing with acidosis. Now, which acidosis I should choose? Is it respiratory or metabolic? So as usual, pH is decreased, and when I look at the PaCO2, it is increase. So they are in the opposite direction. So we will go ahead with respiratory acidosis. Now this bicarb is also high. It is a compensation for the respiratory acidosis. So respiratory acidosis with metabolic alkalosis as a compensation. So that's going to be our diagnosis. So here this is the case of respiratory acidosis with compensatory metabolic alkalosis. I will call this compensation as partial because the pH is not back to normal range. So if this increasing bicarbonate puts the pH back to the normal range, that is 7.35 to 45, within that range, then I would have called it as fully compensated respiratory acidosis. But here it is partially compensated respiratory acidosis. Compensation is happening, bicarbonate is increasing but not able to get the pH back to normal range, right? So answer is respiratory acidosis. Okay. The next question, all of the following are seen in MEN 2B syndrome except parathyroid adenoma, megacolon, mucosal neuroma, marfanoid habitus. What should be the answer? All of them are seen in MEN 2B except. On MEN syndrome, most of the questions come from 2B because apart from the gland involvement, there are extraglandular manifestations that you get in MEN 2B, right? So what are the extraglandular manifestations we get? MEN 2B is, as MEN stands for multiple endocrine neoplasia. These patients have multiple tumors involving endocrine glands, which is due to RET proto-oncogene mutation, and the manifestations include mucosal neuromas, marfanoid habitus, medullated corneal nerves, which can be an image-based question as well. And the components of this MEN 2B include medullary thyroid cancer and pheochromocytoma. There is no hyperparathyroidism, neither parathyroid hyperplasia nor formation of adenoma. These patients can have lichen planus as well as Hirschsprung's disease. So what should be our answer here? We are not expecting to see parathyroid adenoma, right? They can have megacolon, they can have mucosal neuromas, they can have marfanoid habitus. In fact, marfanoid habitus is always given as a clue for the MEN 2B syndrome if it is a clinically oriented question, right? So you may end up getting the image-based questions. As you see here, marfanoid habitus, the mucosal neuromas, and the medullated corneal nerves. All these thread-like structures you're seeing, those are medullated corneal nerves. So please be aware of these image-based questions as well. One more thing, you can get the pes cavus deformity as well in patients with the MEN 2B. Okay, now let's go to the next question. A known case of coronary artery disease was brought with chest pain and palpitations. ECG is shown below. What is the next line of management? So we are dealing with a patient with probably MI. Now he is having palpitations and this is the ECG. I am sure it's not very clearly visible to you. Let me tell you how does it look like. Palpitations is a complaint. Whenever we think of palpitation in the ECG based question, primarily we are thinking of an arrhythmia, right? So think of this ECG as an arrhythmia. So when you have an arrhythmia, what is the first step you will do? You have to see whether it is a narrow complex arrhythmia or a wide complex arrhythmia. Dr. Raj, see, marfanoid habitus primarily refers to tall stature with wide arm span. So merely having tall stature and wide arm span doesn't make someone as having Marfan syndrome. Marfan syndrome has various other clinical features. So if you only have tall stature with wide arm span, we will call it as marfanoid habitus. Marfan's like habitus or Marfan's like body, that's what we mean when we say marfanoid habitus. So here it appears to be wide complexes. The QRS duration appears to be wide. If you get the PPT, you will be able to see the picture clearly. It may not be clearly visible to you on the screen. So we are primarily dealing with a wide complex tachyarrhythmia with the QRS complexes morphologically appearing same in a given lead. They are not different, right? In this lead, they all appear same. In this lead, they all appear same. So what should be my diagnosis in that case? I am dealing with a wide complex tachyarrhythmia with similar morphology of the QRS in the given lead. So it is most likely monomorphic ventricular tachycardia, right? It is a monomorphic VT. So what should be the next line of management? Beta blockers are not considered as the suitable drugs for the management of VT. They are already out. Then amiodarone is considered as the drug of choice for VT, but not in the oral form. So we will go ahead with option B, intravenous amiodarone. So a quick take on the management of this wide complex tachyarrhythmias. Management of wide complex tachyarrhythmias. So wide complex tachyarrhythmias include VT and VF. And when it comes to VT, it could be monomorphic VT as well as polymorphic VT. So when I am dealing with a wide complex tachyarrhythmia, I will categorize them into two groups. One of them will have ventricular fibrillation, which is the most dangerous arrhythmia, because in like atrial fibrillation, where atria is not contracting, merely shaking, in ventricular fibrillation, ventricle is not contracting, merely shaking, which is very dangerous, because if ventricle doesn't contract, no cardiac output means no BP, patient is almost collapsed and he is just seconds to minutes away from death. So it's the most feared arrhythmia. On the other hand, ventricular tachycardia, ventricle is still contracting at but much higher rate. So VT on one side, right? But I will call this as VT with pulse, and VT without pulse is as dangerous as ventricular fibrillation. So pulseless VT will also go into the second group. Pulseless VT will also go into the second group. Okay. Now whenever we have ventricular fibrillation or pulseless VT, the treatment of choice is going to be defibrillation as soon as possible. And if the patient is in ventricular fibrillation, you might have to consider CPR, immediately. Okay, so as soon as you see a patient with VFib or pulseless VT, you have to start CPR, and then as soon as the defibrillator is available, shock them. Why I have to do CPR? Because if they are pulseless, that means blood flow to the brain is already cut off. So to keep the brain alive till I get the rhythm normalized, I need to keep giving the CPR. But if it is VT with pulse, pulse is there means BP may be recordable. So I will look at the BP. So if the BP is less than 90/60, in all patients with low BP, shock is the treatment. But here the treatment changes to cardioversion. So please remember, there are only two conditions where we go for defibrillation. What are the two conditions where we go for defibrillation? These are the two conditions, VFib and pulseless VT, defibrillation. Every other arrhythmia, if BP is low, we go for cardioversion. So even when it is VT with pulse, low BP, cardioversion. And if BP is fair, that is more than 90-60, then we go for pharmacological treatment. You can also call it as pharmacological cardioversion. So what is considered as the drug of choice for treatment of ventricular tachycardia? The drug of choice right now is amiodarone. Alternative to amiodarone, we can use lignocaine. And there is a subtype of VT, in fact a polymorphic VT, which is called as Torsades de Pointes, drug of choice for, if I'm dealing with a, let us say that I got a VT which is pulse and BP is fair, I'm going with drugs, but this VT is Torsades de Pointes type, then the drug of choice is going to be IV magnesium sulfate. So these are all MCQ points I want you to remember. Overall, the drug of choice for VT is amiodarone. If amiodarone is contraindicated, lignocaine can be used. And if it is Torsades de Pointes, then magnesium sulfate. So going back to the question, of course, intravenous amiodarone will be our answer here. Okay, so let's move to the next question now. Multi-drug resistant TB is defined as which of the following? I think all of you know it pretty straight. The resistance to isoniazid and rifampicin is defined as MDR. You are expected to be familiar with the definition of the drug resistant TB, MDR TB and XDR TB, right? So what is the drug resistant TB? Resistance to any one or more than one first line TB agents, we will call it as drug resistant TB. Now if the patient is resistant to rifampicin and isoniazid, then we will call it as MDR. Any other one of the drug is resistant, we will simply call it as drug resistant TB. Isoniazid plus rifampicin combination resistant, MDR. Then what is this extensively drug resistant TB? XDR TB refers to resistance to these two, that is rifampicin plus isoniazid, but in addition to that, resistant to the fluoroquinolones plus, not just the fluoroquinolones, plus resistance to at least one second line injectable drugs. At least one second line injectable drugs. Then we call it as extensively drug resistant TB, right? So here the answer is anyway simple, isoniazid and rifampicin. But in top of this, if I add fluoroquinolones plus one second line injectable drug, then it becomes extensively drug resistant tuberculosis. Okay. Next one, a patient presented with fever, jaundice and malaise. Based on serology reports given below, what is the most likely diagnosis? So patient is positive for anti-HBC IgM, HBsAg positive, anti-HBs negative and anti-HCV antibodies negative. So anti-HCV negative already rules out hepatitis C. So I have to deal with hepatitis B. So is it acute hepatitis B, chronic hepatitis B or chronic hepatitis C? So chronic hepatitis C is also ruled out. I have to decide between acute and chronic hepatitis B. So what do you think it is? Am I dealing with acute hepatitis B or chronic? What is the clue here? HBsAg positive means there is hepatitis B infection present. It doesn't tell you whether it is acute or chronic. Acute or chronic. So if there is no resistance to second line injectable agents, okay, Naman, I will just confirm with the pharmac sir as well. Okay. So here HBsAg positivity means we are dealing with infection with Hep B. It doesn't tell whether it is acute or chronic. So what helps you to tell whether it is acute or chronic? It is the anti-HBC IgM and IgG. So if I have anti-HBC IgM positive, it is always indicative of acute. And if it is IgG positive, then it is suggestive of chronic. So here IgM positive is suggestive of acute infection with hepatitis B. So our answer here is going to be acute hepatitis B. Acute hepatitis B. If it was IgG, I would have gone ahead with chronic hepatitis B. Okay. And if I will give you another profile, let us say that there is a patient with HBsAg positive, sorry, HBsAg is negative, anti-HBs antibody is positive. So what is going to be your diagnosis in this case? And I have one more. And anti-HBc IgM IgG negative. And I have one more patient with HBsAg negative, anti-HBc IgM negative but IgG positive, and anti-HBs antibody is positive. So what do you think is the first circumstance? Yeah, HBsAg is negative. That means currently there is no infection present. Whether he had a past infection or not, that anti-HBc IgG will tell. If IgG was positive, he would have had past infection. So when I see this HBsAg negative, that means there is no current infection. And when I see that IgG is negative, that means there is no past infection either. But still anti-HBs antibody is positive. So what does that mean? That means this patient is vaccinated. So this anti-HBs is because of the vaccination. In fact, in the vaccine, what do we give? We give the surface antigen only. So in the vaccine, we receive surface antigen, body produces antibodies against surface antigen, which is detectable here. But in the second case, HBsAg negative rules out current infection, but this positive IgG indicates that there was past infection, right? Past infection, and this antibody production is because of the past infection. So this is vaccinated, this is past infection recovered or cured, right? Past infection in remission, this is vaccinated. So the second scenario is recovered or cured past infection. In fact, you have to remember one point. The HBsAg and anti-HBs antibodies are mutually exclusive. Now, what do I mean by that? Once the body produces anti-HBs antibodies, HBs goes away. So you will not encounter a patient where there is very high titers of anti-HBs and also very high titers of the HBs antigen. No, you won't get that circumstance. If the antibody comes, antigen goes away. So you will win the battle once your body produces HBs antibodies. Okay. So in this case, we are dealing with acute hepatitis B because IgM is positive and there is HBsAg positive. So there is an infection present. Currently, patient is infected and we are counting it as acute because of the anti-HBc IgM being positive. Okay. Next one. A farmer brought to the emergency with history of OP poisoning managed with atropine and prolidoxime. On day 2, he developed high fever. What is the likely cause? It's a very simple pharma question. So what do you think should be the answer here? OP poisoning, mainly we treat them with atropine and prolidoxime. Okay, so what is the current status of prolidoxime? Dr. Vikash, yes. Patient had the infection in the past. Now he is infection free. He is in remission. Atropine and prolidoxime. What is the current status of prolidoxime? Is it recommended? WHO still continues to recommend use of pyrrolidoxime, but Indian studies are not in favor of pyrrolidoxime. Studies have shown that it doesn't give any benefit. So mainstay is treat with atropine. So can any of these drugs cause the side effect? Side effect of pyrrolidoxime mainly is it is hepatotoxic. And there is one more similar drug to pyrrolidoxime, which is obidoxime. Obidoxime is more hepatotoxic than pyrrolidoxime. Obidoxime is more hepatotoxic than pyrrolidoxime. So pyrrolidoxime cannot explain why he has developed fever, right? OP poisoning does not cause fever. In fact, it can cause hypothermia. Organophosphate poisoning sometimes can cause hypothermia. So unlikely to be the cause. Aspiration pneumonia, there is nothing else suggestive of aspiration pneumonia, and aspiration pneumonia per se does not directly cause fever. But if patient develops some hospital acquired secondary infection may, but then directly that does not explain. So I have to explain it through chain of events. Aspiration, then aspiration pneumonia, secondary bacterial infection, then fever, like a hospital acquired pneumonia. But atropine, we all know, is known to cause rise in the body temperature, right? Atropine is a well-known cause for hyperthermia as well. So atropine explains why he would have fever. In fact, if you are working in a government medical college, you see these OP poisoning patients every now and then, and most of them will have the atropine side effects once we are treating them with the atropine for OP poisoning. They will be having atropine psychosis, agitated, having hyperthermia. Your staff nurses will be recording graphs with high fevers constantly. It's a well-known thing. So atropine explains, so our answer will be atropine. Okay, the next question. A lady noticed that her husband is unable to express emotions. He also had tremors and slowness of gait. So what is the possible site of lesion? So what is the diagnosis here? Unable to express emotions, right? So in other words, it looks like patient has worn a mask-like face. Then tremors and slowness of gait, that is bradykinesia. So whenever you think of tremor and bradykinesia, what is the diagnosis that comes to your mind? Parkinson disease or other closely related symptoms like Parkinson plus syndrome, right? Parkinson plus syndrome. So at least I can say that I am dealing with Parkinsonism here. Parkinsonism. And even mask-like face can be explained with that. So what is the possible site of lesion? Is it cerebellum? No. What symptoms we get when we have cerebellum? We can have ataxia, nystagmus, right? Action tremor. Then it can't be hippocampus, premotor cortex. No. Most of the movement disorders are because of a basal ganglia lesion. And please remember, substantia nigra is one of the nucleus which is considered as part of the basal ganglia. So answer here should be basal ganglia. And the important thing I want you to remember with respect to movement disorders is the site of lesions. So basal ganglia has several nuclei, and they ask you site of lesion in various movement disorders. So as we already know, Parkinson disease is substantia nigra, which is one of the nucleus belonging to the basal ganglia. So in Parkinson's, it's going to be substantia nigra pars compacta, or in simple words, substantia nigra. Okay, then we have this chorea, we have athetosis, and we have Balismus. If all of these are unilateral, we can also call them as hemichorea, hemibalismus, hemiathetosis. The site of lesion for chorea is mainly caudate nucleus. Caudate nucleus of the basal ganglia. The site of lesion for the athetosis can be putamen or globus pallidus. Globus pallidus. And for the balismus, it is the subthalamic nucleus. Subthalamic nucleus of Lewis or subthalamic nucleus. Okay, so these are the sites of lesions for us to develop these movement disorders. Sometimes the question may indeed give you a story and then they will ask you what is the site of lesion. Like in this case, there is a story, right? From the story, we recognize that it is talking about Parkinsonism. So it is substantia nigra, and because it is a general question, we are sticking to basal ganglia. But if they had mentioned substantia nigra, caudate nucleus and all, we would have chosen substantia nigra, right? Similarly, there can be story of chorea, there can be story of athetosis or balismus. So how will I recognize that it is a story of chorea? The story of chorea will be characterized by description of the movements as dance-like involuntary movements. Dance-like involuntary movements. So please remember the word chorea actually comes from choreography. So it looks like someone has choreographed the movements. So whenever you see word dance-like involuntary movements, think of chorea. Okay. Then if the involuntary movements seen are described as snake-like or writhing movements, snake-like or writhing movements, think of athetosis. And if the movements are described as violent flinging movements, then think of balismus. So any question which says here's a patient who presented with involuntary movements which are violent and flinging, think of balismus. And then they are asking you what is a probable site of lesion? It is going to be subthalamic nucleus. If the description is that patient has involuntary movements which are kind of dance-like, think of chorea. So Abhilash, yes. So apart from that, yes, in chorea you can have this milkmaid's grip and trombone tongue. You can have involuntary movements involving the tongue as well as the hands. So you get this thing called as milkmaid's grip. And trombone tongue. They also have these involuntary movements of the tongue. Tongue also keeps moving like a bag of worms. And then you have this milkmaid's grip. So if you ask them to shake your hand, they'll keep squeezing as if they are going to milk your fingers. That's what is called as milkmaid's grip. Okay. Now how do I remember these sites? Parkinson's, all of you know. Caudate for chorea is easy to remember. C for C. Chorea, caudate. Okay. Now, how do I remember? What if I get confused between athetosis and balismus? No, you will not get confused. Why? I want you to remember cricket ball. Balismus is cricket ball, right? And if I want you to fling the ball far away, which batsman will you choose? If you have to fling the ball far away out of the stadium, which batsman you will choose? I will choose my favorite, Tala, who you know whom I am talking about, right? So whenever ball comes to the stadium, Tala comes into picture. So balismus is subthalamic nucleus. Tala is a pet name for Dhoni, right? So balismus is due to lesion in subthalamic nucleus. So then whatever is left, putamen, globus pallidus, you can go with athetosis, right? So that is about some MCQs on the movement disorders. Okay, so here we have the next question. From the image given below, identify the murmur depicted. So what is a murmur here? The murmur is happening between S1 and S2, right? A to P2 is our S2 and this is S1, and murmur starts with S1, ends with S2. So that means we are dealing with pan-systolic murmur. Pan-systolic murmur. So among the given choices, which of them is a pan-systolic murmur? Tricuspid stenosis is a mid-diastolic murmur with pre-systolic accentuation. So how that murmur is going to look like? The TS murmur is going to look like this. It is a diastolic murmur. So it is going to happen between S2 and S1. It's a mid diastolic murmur. So somewhere here it will start with an opening snap, and then the murmur will appear, and the murmur intensity will increase before the next systole begins. So this is a classical mid diastolic murmur with pre-systolic accentuation. This is a mid diastolic murmur with pre-systolic accentuation. Same murmur I am going to get in patients with mitral stenosis as well. What is the murmur of pulmonic regurgitation? Murmur of pulmonic regurgitation and the aortic regurgitation is same. It is a diastolic murmur. It's a early diastolic murmur. So it's going to happen between S2 and S1, and it only runs in the initial part. It's going to be a early diastolic murmur. You can call it as early diastolic decrescendo murmur. It's an EDM, early diastolic decrescendo murmur. What is the murmur of the AS? The murmur of AS is an ejection systolic crescendo decrescendo murmur. Systolic means it will be happening between S1 and S2. It starts in the middle of the systole with a click, which is called as an ejection click. The murmur intensity goes on increasing, then goes on decreasing. The classical diamond shaped murmur, or it's an ejection systolic murmur which can be described as crescendo decrescendo, crescendo decrescendo. The murmur of MR and TR is pansystolic, the classical picture that we are getting here. So what should be our answer here? We are getting this pansystolic murmur in MR or TR. So from the image given below, it is called a phonocardiogram. My diagnosis is going to be mitral regurgitation, MR. Okay. Next question. What will be the role of TPA in the management of myocardial infarction? Okay, that's a very simple pharmacology question. What TPA does? TPA, tissue plasminogen activator. So what it does it inhibit the platelet aggregation, inhibit thrombin or fibrinolysis? So platelet aggregation is inhibited by antiplatelets. It is the fibrinolysis which is the function of the TPA. So normally what happens is, when we form a blood clot, we convert fibrinogen to fibrin, and this fibrin gets deposited as a mesh in the clot. But once the job of the clot is done, now I have to dissolve this fibrin. This fibrin is dissolved by an enzyme called as plasmin. But this plasmin exists. Once I dissolve the fibrin, it becomes fibrin degradation products. They are called as fibrin degradation products. Fibrin degradation products. But this plasmin generally exists in an inactive form called as plasminogen. So it will get only activated when the healing, like a clot means it's a response to trauma to blood vessels. So once it is healed, now there is no need for the fibrin to be present there, I can clear. So then this gets activated. This conversion of plasminogen to plasmin is done by tissue plasminogen activator or TPA. So it activates the plasmin. That plasmin will break down the fibrin to fibrin degradation products, and that's how body clears the clots. So when I am trying to treat a case of MI, there is already, let us say, a clot. I want to dissolve it. So what do? So far we haven't developed drugs which mimic plasmin. So what we do is, we will make use of naturally produced plasmin in the body by converting the plasminogen to plasmin with the help of an externally administered TPA. So it is primarily causing the fibrinolysis, right? It is neither inhibiting thrombin nor the platelet aggregation. Okay, so here's our next question. A patient who was on treatment for hypertension developed hyperkalemia. ECG has been depicted below. Which of the following drug can cause this side effect. So basically the ECG shows tall tented T waves, if you are able to see. So ECG is showing tall tented T waves, which we all know it is suggestive of hyperkalemia. So this is a patient who was on treatment for hypertension, has developed hyperkalemia. That's it. That's the story. So which of the following drug is known to cause hyperkalemia is the question, right? Beta blockers, do they cause? No. Hydrochlorothiazide, in fact, it is known to cause hypokalemia, right? It causes hyponatremia and hypokalemia. It can cause hyponatremia as well as hypokalemia. You lose electrolytes proficiently. It is the potassium sparing diuretic like spironolactone which are known to cause hyperkalemia. It's again a very simple, straightforward question. Okay. Now here's the next question. An elderly male presented with is a known case of prior MI presented with ventricular tachyarrhythmia. So we are dealing with a case of VT, treated for 4 years with medications. Okay, bit strange. He had dry cough, dyspnea and fatigue for past 3 to 4 months. He also developed hypothyroidism. Which drug responsible for this condition would be? Okay, so ideally I wouldn't have framed it as ventricular tachycardia, rather I would have called it as, let us say, AFib. Because if you are having recurrent attacks of VT, treating with the antiarrhythmics is not a good choice. What is the best way of treating a recurrent attack of VT? Which conditions? Okay, this is also an MCQ zone. Which conditions you get are associated with recurrent attacks of VT? Recurrent attacks of ventricular arrhythmias, attacks of both VT as well as VFib. What all conditions are associated with recurrent attacks of VT? The first thing that should come to your mind when patient is having history of recurrent attacks of VT is hypertrophic cardiomyopathy or hypertrophic obstructive cardiomyopathy. The second one is ischemic heart disease. Ischemic heart disease. So if you have MI or any form of ischemic heart disease, you are at increased risk of developing VTVF, especially if you have ejection fraction less than 35%. There is high risk of developing recurrent attacks of VT. Okay. The third one is there is something called as arrhythmogenic right ventricular dysplasia, where on the ECG you get that epsilon wave, ARVD. Okay. Then fourth one, congenital long QT syndrome. Long QT syndrome, right? At least these are the 4 important conditions that should come to your mind when patient is having recurrent attacks of VT or VFib. In all these cases, when there is recurrent attack of VT or VFib, how do we manage? Management is preferably with what we call as implantable cardioverter defibrillator. Implantable cardioverter defibrillator. And implant a defibrillator in the patient's body, it senses when there is arrhythmia, it shocks. I forgot to add one more. Even in patients with dilated cardiomyopathy. In fact, this dilated cardiomyopathy will fit under this. Their ejection fraction will also be low. So we think of drugs in these conditions when there are no attacks, but because these are risk factors for attacks, for the prevention before attacks happen, we can use beta blockers or amiodarone. But once an attack has happened and it happens again and again, we have to put them on implantable cardioverter defibrillator. So drugs are used for prevention, not for treatment. So once recurrent attacks are there, they should be on implantable cardioverter defibrillator. So that's why I'm just reframing the question. If I was treating this patient with ventricular arrhythmia, right, with ventricular arrhythmias, I wouldn't probably be keeping him on just medication, but rather I would be putting him on ICD. Okay. But AFib, we do put them on long-term antiarrhythmic medications. So he was on medication for antiarrhythmia with, let us say, afibrillation. He was on antiarrhythmics, and from past 3 to 4 months, he is developing dry cough, dyspnea, and fatigue, dry cough, dyspnea and fatigue. And he has also developed hypothyroidism. Which of the following drug can be responsible? Okay, now among the drugs, the ACE inhibitors and the beta blockers can explain the cough. Beta blockers, especially if he is asthmatic, can precipitate cough. ACE inhibitors are known to cause cough, but they cannot explain hypothyroidism. Beta blockers can cause some degree of symptoms of hypothyroidism because thyroid symptoms are primarily related to sympathetic activity. But a documented hypothyroidism you will not get, only symptoms you get. But TSH, T3, T4 will turn out to be normal if it is patient on beta blocker. So I can rule them out. Now furosemide neither explains cough and respiratory symptoms nor hypothyroidism. Only thing that explains both is amiodarone. Amiodarone is known to cause. There is something called as amiodarone induced thyrotoxicity, right, where it can cause hypo as well as hyperthyroidism. Second, it is known to cause pulmonary fibrosis. It is also known to cause retroperitoneal fibrosis. So patient developing a pulmonary fibrosis explains why he is having dry cough, dyspnea and fatigue. And amiodarone induced thyrotoxicity or amiodarone induced thyroid injury explains why he is developing hypothyroidism. So we can stick to amiodarone as the answer, because lisinopril may explain respiratory symptoms but not hypothyroidism. Metoprolol may explain the respiratory symptoms in presence of asthma, which is not there in the story. So we'll stick to our answer A, amiodarone, known to cause both thyroid dysfunction as well as the okay. So next question, a 50-year-old male chronic smoker presented with pain in the right arm. On examination, ptosis was noted. Chest X-ray revealed an image depicted below. What is the most likely diagnosis? So I think it's very simple and straightforward. There is an opacity and ptosis, right? So we are dealing with Horner syndrome, and what comes to your mind? So whenever we are thinking of Horner syndrome plus a lung tumor, it has to be a Pancoast tumor. This tumor may be compressing the cervical sympathetic ganglion, giving rise to the Horner syndrome. So plus there is also a history of smoking given, so we'll go ahead with Pancoast tumor. It is not cervical radiculopathy. Cervical radiculopathy would have given rise to the radicular pain. Brachial plexus injury would have given rise to the weakness of the upper limb muscles. Carpal tunnel syndrome, you are also very much familiar with symptoms, so it's simple, again a straightforward question. It's Pancoast tumor. Okay, so I think we have completed the questions listed for today. We still have the questions to be covered from the hematology, hepatology and respiratory medicine. So like we are already running quite late for the day. So I will be scheduling one more session where we will try to cover the remaining three major systems from medicine. Hopefully within a week's time. Once it is scheduled, I will share the link on the Telegram as well as the Instagram. I'll see you in the next class. Till then, study well, and please guys, make sure that you attempt your grand test, because nothing comes closer to the real world examination as seriously giving the GTs. So we are now doing the NEET PG predictor GTs, which are live. So attempt and keep giving the GTs, and follow the Sankalp group on the Telegram, where Dr. Rishabh and the team, along with all the faculties of the MedEd, we are constantly covering tiny important topics which are helpful for the upcoming NEET PG exam. So be aware, be active on the Telegram group and keep following us for the updates. Okay, so that's it from me today. I'll see you in the next class. Till then, have a good time. See you. Bye-bye. Thank you all guys. Thank you. Thank you. The PDF guys, PDF will be available on the Telegram within half an hour or so. Yeah. Thank you. Thank you.